चलो उसी से वो बंद
எப்படி இருக்கீங்க சார்?
நல்லா இருக்கும்பா. நீங்க எல்லாம் நல்லா இருக்கீங்களா?
Yes sir, doing fine sir.
Very good, very good. Nice to see you.
Yes sir.
So கரெக்டான ஹால்ல தான் வந்திருக்கேன் நானு. எனக்கு அதான் டவுட். கரெக்டான ஹால்ல வந்திருக்குமா?
எப்படி இருக்கு சார் கோவிட் மெட்ராஸ்ல சார்?
குறைஞ்சிட்டு வருதுப்பா, பரவாயில்ல பரவாயில்ல. ஏன்னா எல்லா இடத்துலயும் அந்த நம்பர் ஆஃப் பேஷண்ட்ஸ் குறைஞ்சிட்டு வருது. பட் நாங்க வந்து யூஸ்வல் ப்ரிகாஷன்ஸ் எடுத்துட்டு தான் பண்ணிட்டு இருக்கிறோம். பண்ண ஆரம்பிச்சிட்டோம். இதுக்கு முன்னாடி பயந்துட்டோம், இப்ப பண்ண ஆரம்பிச்சிட்டோம்.
இனியும் கேसेस கம்மி ஆயிடுச்சுங்க சார்.
வெரி குட். செகண்ட் வேவ் வரும்ன்றாங்க, பயமுறுத்துறாங்க சிலர்.
ஆமா சார், ஆமா சார்.
அதுதான்
சன் எப்படி இருக்காரு சார்?
நல்லா இருக்காருப்பா. தேங்க்யூ.
Good morning, Lokesh sir.
Hello. Hi, good morning.
Good morning, Lokesh. Dr. Ramesh Babu here.
Yeah, good morning, Dr. Ramesh. Yeah.
Good morning. Nice to see you.
Same here. Nice.
You are from Bangalore, Lokesh?
Yes, yes. I'm from. Yeah.
Which hospital?
I'm in Manipal.
Manipal.
Yeah. Good.
How is the COVID situation in?
Sharat Rao is the dean, isn't it?
Yes, sir. Hello.
Sharat Rao is the dean. Am I right? Sharat. Sharat.
No. Sharat Rao. No. I'm in Bangalore, Manipal. There is a Manipal.
Oh, Bangalore.
I'm in Bangalore, Manipal. Manipal. This one is different. Manipal.
Okay.
Bangalore, Manipal. Yeah.
ఇక్కడ చేసే ఫస్ట్ అయిపోయిందా
How is the COVID situation in Bangalore, sir?
Okay. Actually, they say it is coming down. But yeah, because the patients have come down. IPE in the hospitals, very less COVID patients. I mean, people have realized it's better to stay home, I think, rather than spend money.
Professor Dinesh is coming.
I think so. Yeah, he will be there. Hi,
Okay.
Ashok.
Hi, good morning.
Morning.
Hello, Ashok.
Good morning, sir. Good, sir. How are you, sir? Sir, along with you, Dr. Achutra also will be sharing your moderating the session of pelvis.
Who is the
Dr.
other
Dr. Achutra.
Achut Rao, huh?
Yes, sir.
He's
He's
from which place?
He's from Kurnool, sir.
Oh.
Yeah. Good morning, everybody.
గుడ్ మార్నింగ్ సార్
Good morning.
Good morning.
I think this is going to be the first time that we are conducting something like this in OASISCon, and I think it's a
Hope it is the last
pre-recorded.
time.
This is the first and the last time, as sir is saying. Yeah. So the thing will be Dr. Ramesh Babu sir and Dr. Chitra will be moderating the pelvis session, where you have a talk on how to resuscitate, followed by what mistakes not to be done while doing a symphyseal plating, and how to go about doing a SI screw fixation. Then, if time permits, we have session of 5 minutes of question and answer, then followed by the established session, where we have divided into basic, then followed by regular two most common fractures what we regularly see in the acetabulum, and followed by two topics which involve complex pelvis and established fractures. Because a lot of postgraduates attend this conference, keeping that in mind, we have divided into basic and a little advanced also in this session. Followed this, we have question answers for around 10 minutes. Then we start our panel discussion on case discussions. Then I think there are two free papers which have to be present. Those two papers will be presented, and followed that, I think that's the end of this pelvis and established session. We are all sitting in a hall here, so I am with a mask. I think we might be hearing a lot of other noises when we are presenting, because we are all together, all subspecialties in one hall. So I think you might hear some background noises from my side.
Can't mute it.
I will mute it, sir, during the presentation. When I speak, I think you can still hear it, certain things in the background.
Yeah. But I think I should congratulate the OASISCon team.
Yeah.
You are doing a great job. I
It's
was
a,
watching various topics. Very
Yeah.
well covered. Excellent.
yeah.
Excellent.
I
Kudos
think
to the scientific team.
yes, I think there's a great effort from the organizing committee. They have been through this from past 2-3 months vigorously with so many mails and so many WhatsApp messages and lot of because it's a new way of doing a lot of questions, lot of doubts how to go about it. There might be some lag in sharing of screen, uh, and things may happen like that because it is not under my control. I have to ask the main person who is involved in
No,
this.
but one thing is good is you have given all our presentation directly. So there is no problem. Even if the net goes here, the presentation will continue.
Yeah, that's true, sir. Only if there's some technical issues from our side, I think you have to present online.
So you. But then I don't have it here on my
I welcome Professor Dinesh.
morning, sir.
Good morning. Sir, I am Dr. Ramesh from Chennai. I just want to know if you are from Dinesh.
I couldn't hear you. You are Ramesh Babu from Chennai. That much I heard.
Yeah. How about yourself?
I am from a small city in Karnataka called Belgavi.
Welcome.
Yes, Belgaum.
Welcome. Belgaum is not a small town.
Yeah, it's a small town.
No, big doctor, but
Belgaum is more of an educational hub like Manipal now.
Yes, yes.
we are interested in the big doctor, not the small town.
Yes, sir.
So
By
Dr.
size,
Dinesh is the big doctor.
I am big, 6 feet.
No,
That's
no,
all.
no, not by size.
You are in which institute, sir?
I'm in Jawaharlal Nehru Medical College.
Private, huh?
Yeah, it's a private medical college.
So good morning, everybody.
Morning, sir. Good
morning, sir.
Good morning, sir.
Good morning, sir.
Kindly message him once, no?
Dr. Ramesh Babu, you are from which college, sir?
Previously, I was at government.
Call him up.
Now I am on my own. Retired.
You are from Government Medical College, Chennai.
I was at Kilpauk Medical College.
Okay, Jilpok.
Then I moved to Ramachandra.
Okay.
Now on my own at Spot Hospital.
Ashok, will we have this for recording available later viewing? Ashok,
Hello. Yeah.
will we have the recording of this available for later viewing? I was asking. Is it
I'll
possible?
just find out from these guys and let you know.
Yeah.
Yeah.
So some of my students wanted this. Everybody had not registered. Some have registered, some have not. So we thought we will share it with them. If it is available.
Yeah. Please do confirm with regard to recording. Dr. Achyut Rao is here. Yeah, I think he's there.
Hi, Ashok.
Hi, Achyut Rao.
I think 9:30.
Yeah, I think it's a minute less. Okay. Today, can we start?
Hello. All panelists mic off.
Hello. Shall we? Yeah, I think it's 9:29. Shall we all start?
9:30 sharp, Ashok. Ashok Sunil Gavaskar
Okay, sir.
join. Ashok Sunil Gavaskar.
Yeah, I think he is going to log in another 2-3 minutes. That's what the message says.
Okay.
Yeah.
Good morning, Ashok.
Uh, uh, g- good morning. Uh,
Welcome, welcome, Ashok.
yeah, Ashok
Thank you, sir.
is
Thank you.
there.
I got the
Okay.
link from him only, so I want everybody to wait for him.
Yeah. So, okay, I think we can start the session. Thank you all for accepting
Greetings to all of you.
on this. Okay.
Warm greetings to all of you. Strategies of resuscitation following pelvic fractures. Are we up to date? As you all know, the pelvic disruptions causes
Ramesh,
hemodynamic
I want to
instability
discuss it, huh?
in unstable injuries, and there is a high mortality
Ashok,
up to 50% in all these injuries. Hence, the protocol-based strategies are critical in the outcome. It varies according to the region and availability of infrastructure. Pre-hospital phase is the most
Ashok, can you
crucial
hear?
time, where the scoop and run
Ashok,
approach
Raju.
is one of the prescribed one, but the platinum of 10 minutes in the golden hour has been saved in these injuries. Early onset application of pelvic binder is one of the mainstay in the pre-hospital phase management. In Indian scenario, pelvic binder usage has been seen in 59% of the patients. In Western countries, there has been up to 75% of the patients receiving a pelvic binder on site of the incident, and it is most beneficial in types B and C type injuries. It gives a circumferential compression of up to 61%. In an emergency room, when the patient was suspected to have a pelvic instability, patient should receive a sheet, its circumferential one, or a pelvic binder. It should be applied at the level of greater trochanter. The initial assessment resuscitation follows the ATLS protocol, which gives a good amount of decision making, and handling of injuries are important by this trained personnel as it directly reduces the mortality. Resuscitation has been described as a massive or a damage control resuscitation. When the anesthetists are involved in resuscitation, we should look for an external examination findings, particularly related to the pelvic injuries or the deep lacerations, which may be a part of open pelvic injury, perianal or a perivaginal lacerations. Blood at the urethral meatus may be indicative of urethral injury, and closed degloving injuries of moral level lesions, which can be identified in the upper part of the thigh or in the lateral aspect of thigh or in the back, designated as a chimney effect or a butterfly hematoma. In hemodynamic instability, blood loss is expected around 2 to 3 liters in these unstable injuries with an hypotension of less than 90 millimeters of mercury. Resuscitation has been described as supranormal massive transfusion or aggressive resuscitation, which might be detrimental in many situations like a pop the clot phenomena. The clot might displace and arterial bleeding becomes more pronounced, and mean arterial blood pressure may rise in a head injury patient. It may cause the lethal triad of trauma, coagulation, coagulopathy, hypothermia, and acidosis. Hence, the term has been coined as a damage control resuscitation. It has got 3 steps. Permissive hypotension, where the systolic blood pressure maintained between 80 to 90 millimeter mercury, as it maintains the end organ perfusion and mean arterial blood pressure. And hemostatic resuscitation using a blood products, where the dilution coagulopathy is also addressed. And damage control orthopedy includes skeletal stabilization of pelvis, particularly in the form of pelvic external fixation. Optimal fluid has been debated over a long period of time, and isotonic chlorine is the preferred crystalloid at present, and the amount is reduced from 2 liters to 1 liter as per the modified ATLS protocol. And blood products as we use in 1:1:1 ratio with the form of platelet packed blood cells, fresh frozen plasma, and platelets. Whole blood in massive transfusion, there is a chance for hypothermia and acidosis. However, randomized trials are being conducted in comparing the whole blood and the blood product. Tranexamic acid is useful within 3 hours of injury. The hemodynamic instability following resuscitation, when the stability is achieved, patient can be shifted for imaging as per the X-ray and whole body CT. When the patient is still unstable, we have to trace the source with using other forms of investigation like FAST, with focus assessment with sonography for trauma. It detects the blood in the peritoneal cavity with sensitivity of 85 to 95%. It requires only less than 5 minutes for the experienced physician. And EFAST is the current addition using a thoracic cavity screening to look for the hemothorax. And standard image include chest X-ray and pelvic X-ray, which gives a gross estimation of the injury, where a pubic symphysis and SHG disruption, it gives an estimate of the disrupted pelvic. However, 67% of the patients where the posterior ring is not detected with an X-ray. As per the Young and Burgess classification, it directly correlates with the severity of hemorrhage and blood transfusion, as the severity of the pelvic injury goes higher in the form of APC3, LC2, and vertical shear injuries. And whole body CT has been described as a tunnel of death and unstable injury. Hence, the patient has to be shifted to CT scan when the patient is hemodynamically stable. And there has been a comparison between whole body CT and selective regional CT. In 31% of selective CT patients, the missed injuries are reported. Hence, the whole body CT is the preferred method in the recent times. This is an example of a 38-year-old male who had a suspected pelvic injury with a perineal laceration, was given a pelvic binder, and a damage resuscitation was attempted, and then fast showed hemoperitoneum. Once the patient has been hemodynamically stable, an X-ray and CT scan was done showing an APC injury, the distal femur, and bowel injury, where a damage control surgery was performed in the form of wound debridement, pelvic X-fix application, laparotomy, pelvic packing with a colostomy. Pelvic external fixator plays the most crucial initial management, as it closes the pelvic volume and gives a good tamponade effect. The types of fixator are using an iliac crest, supraacetabular, or an anterior inferior iliac spine. Pelvic C-clamp is not widely used now. Pelvic packing is a safe and effective adjunct to arterial embolization. Is more often complementary to the pelvic external feed. Is justified because of most of the bleeding are from venous and the cancers bone build. A larger shears have shown reduction in the mortality. The role of primary fixation in the injuries are very much limited, as the laparotomy incision can be used for a symphytic disruption. Here you can see an example of a bladder injury, pubic symphytic disruption. Both the problems are addressed in the same time. Iliosacral screws have been described as a part of an anti-shock or a part of resuscitation. However, this needs a trained personnel and an experienced team to perform this procedure. In patients who have got a failed damage control resuscitation, the large pelvic hematoma and the contrast blush on the whole body CT, and persistent hemodynamic instability following a pelvic X-fix and pelvic packing, angiography and embolization indicate. As you all know, the bleeding sources in most of these injuries are venous bleed and cancers bone bleed up to 95%. Arterial bleeding is reported only up to 2.3%. Hence, it has got a sensitivity of up to 90%, success rate of 100%, but there are complications of mortality, rebleeding, and complications have been reported up to 66%. Hence, all these three have been combined. 3-in-1 protocol has been described, all in one session, but vast amount of workforce is needed in all these injuries. The last one is the Riboya resuscitative endovascular balloon occlusion. Is one of the last resort in persistent hemodynamic instability. It needs a vast amount of workforce and the temporary occlusion of aorta, but higher complication rate with survival of 46% have been reported. Ganga Hospital, we are practicing our algorithmic approach in managing all these injuries, and it has been published in JCOT in the recent month. Hence, to conclude, pre-hospital care with pelvic binder and transfer to a trauma center is the mainstay in the treatment. Algorithmic approach is critical in the management of these injuries. Damage control resuscitation with 1:1 ratio is the preferred method in the recent times. Pelvic X-fix and pelvic packing plays key role in the initial management, and angiography embolization is indicated in a persistent hemodynamic instability. Thanks for your patient listening.
Thank you, Dr. Ramesh Perumal. Excellent talk on the first topic, which is strategies of resuscitation following pelvic fractures. And I think the pelvic fracture is an excellent topic to start with. This is the first session for the penultimate day, and we have got excellent speakers. And just now we heard about Dr. Ramesh Perumal, who is from Ganga Hospital. We have got a large series of management of unstable pelvic fractures as well as open injuries. And next we have Dr. Ashok Sunil Gavaskar, who is a consultant orthopedic surgeon from Rela Hospital, Chennai, and he's going to talk to us on pubic symphysis, ORIF, pitfalls and mistakes to avoid. This session has been well covered because, as you know, the pelvic fracture is one of the major injuries which can lead to mortality, high incidence of mortality. So now you heard about Dr. Ramesh talking about resuscitation so that you can save the patient. And now next is we are going to, as you know, the pelvis has got two structures. One is the anterior and posterior. Both are equally important. Now we are going to have Dr. Ashok Sunil Gavaskar who is going to talk to us about management of anterior instability, that is pubic symphysis management. Next, we will have Professor Dinesh R. Kale from Belgaum, who is the professor of Jawaharlal Nehru Medical College, Belgaum, who is going to talk to us about the posterior fixation. Over to Dr. Ashok Sunil Gavaskar. We are waiting for your talk. I think it is a recorded talk. The organizers can proceed with the presentation.
Hi everyone, this is Dr. Ashok from Chennai. Pubic symphysis or IF is a pretty common technique with reliable results, but there are problem areas which you could encounter if you are not careful with execution or evaluation. So the more common issues to deal with include acute fixation failure, which is more common due to our oversight if you do not look into the entire spectrum of pelvic ring instability. The symphysis being a mobile articulation, late fixation failures are actually much more common, and you shouldn't forget to discuss this with the patient. Some of these failures may not be relevant, but you should make sure the patient knows this before they undergo the surgery. So if you want to avoid acute or late fixation failures, you need to focus a lot on how you achieve your reduction and how you use your implant. We'll try to focus some of the problem areas and mistakes to avoid with regards to that. And also be cognizant of the fact there are some instances where ORIF may not be ideal and you have to rely on alternate techniques. So if you look at this patient, like with a, you can see a symphyseal disruption is quite obvious, but you can also see a subtle posterior ring injury on the right side. And if you go back to the CT scan, you can see the anterior SI joint is disrupted, whereas the posterior part is still intact. The question that often comes to our mind is like, is anterior ring fixation alone is sufficient in this case? Maybe, but at an expense of high risk of acute failures. If you look at this paper, like combined anterior and posterior fixation in APC2 injury is definitely superior in terms of eliminating acute failures. So whenever you have an APC2 injury, consider to use an additional posterior fixation to protect your anterior fixation. Another common reason for acute fixation failure is not using sufficient fixation on the symphysis. A two-hole plate is a definite no-no. We don't use it nowadays too often, but it was a very common thing to do previously. And symphysis being a mobile articulation starts to toggle and rotate on the single screw as a pivot. And if you're using a two-screw construct, even a posterior fixation will not protect you from failures. So two things that to remember to prevent acute fixation failures include, do not underestimate the posterior ring injury, be liberal to use iliosacral fixation in addition to anterior ORIF, and always use a multi-hole plate on the symphysis with sufficient fixation points. If you look at this case, a type C injury, which I stabilized with an anteroposterior construct, these are the initial x-rays. But if you look at 4 months, there is definite movement of the symphysis causing some loss of reduction. So the question is this a cause for concern? If you are not aware, radiographic failure of symphysis in a late manner is much, much more common. As shown in this paper, almost 75% of people have some sort of radiographic picture of failure. But this is benign most of the time. Some even consider it physiological as symphysis regains its mobility. And the functional relevance is not important most of the time. Most people return to their original work without any problems. And according to this paper, only 1% of patients require some sort of intervention to address that. Another important thing to consider is sequencing. Where do you start and where do you finish? If you look at this patient with the pelvic ring injury, you have a symphyseal disruption, but you also have a SI joint disruption on the left side. So the question is, where do I start, posterior or anterior? Because this is important because it can actually affect the quality of your anterior ring reduction. Our preference is to start anteriorly in a type B injury. As you can see, clamp anteriorly automatically almost all the time reduces your posterior ring as well, and then you can go again and stabilize these injuries. For type C injuries, you can still use the anterior ring as an hinge point, it helps in posterior reduction most of the time, and then you can get your posterior fixation to do the job. But there are exceptions, and you need to be aware of that. How do we reduce our symphysis? Most of the times we use clamps to reduce this. Weber clamp is probably the most commonly used one, but you have to be careful that you need to reduce your symphysis in multiple planes. If you can see the X-ray image on the left, we have got the rotation correct, but in the flexion extension plane, there is still a malreduction. So if you're using Weber clamps, be cognizant of this fact, and you might have to use multiple clamps sometimes to achieve reduction in other planes too. Screw-based clamps are an important tool as well. They are very powerful, and you can often use one clamp to achieve multiplanar reduction, but they also hinder your access a bit. So you need to be familiar with using them. With regards to your plating technique, make sure you use a plate that is robust. We always prefer at least a 6-hole plate. Sometimes it might go up to 8 or 10 hole depending on the injury pattern. Position them carefully. Make sure you contour them to accommodate the pubic contours. And also position your plate a little bit more anteriorly so that you can get trajectory for your long parasymphysial screws. If you position them posteriorly, you sort of tend to lose that. Also, when you go laterally, be cognizant of the structures at risk, the corona mortis, external iliac vessels, and if you're using a longer plate and screws directed laterally, you also have to be careful about the obturated neurovascular bundle. And if you're using a converging screw pattern, also be careful about hitting the urethra. And always check for longer screws because it's an extremely sensitive area, especially in females, and avoid long screws in this position. Sometimes it may not be ideal to do an ORIF in all cases, like in this patient to add a massive bladder injury, which was repaired. And we always tell our urologists to keep the SPC as high and as lateral as possible. And even if that happens, sometimes due to the delay, we may not be able to do an ORIF. And in such cases, the internal fixator is a good option. It can be used in cases where you have associated bladder or urethral injuries, open fractures, obese patients, and also in younger females to avoid that sensitive area. So in summary, symphysial ORIF is a simple technique. If you can focus on reduction and plating, you can get good results almost all the time. Be mindful of early failures. Do not underestimate posterior pelvic ring instability, and be liberal about adding posterior fixation whenever you are in doubt. Late failures are common, but they are often radiographic and doesn't affect function. Thank you.
Thank you, Dr. Ashok. Excellent talk. I welcome Dr. Achyuta Rao from Kurnool, who has joined me in chairing this session. Welcome, Achyuta Rao.
Hi, sir.
Hello. We will move on to the next talk by Professor Dinesh R. Kale from Belgaum. As I was telling you earlier, he is the professor at Jawaharlal Nehru Medical College, Belgaum, and he is going to talk to us about the posterior fixation, fluoroscopy-based technique of iliosacral screw fixation, SI joint, and sacral fracture. Over to Dr. Kale.
Everybody, I am Dr. Dinesh Kale, Professor of Orthopedic at the Department of Orthopedic, Jain Medical College, Belgaum. Today I am going to demonstrate to you how should you start your pelviacetabular case draping and the adjustment of the IITV. It's very essential that before you drape the patient, you should be familiar with the images that you are getting. Do not have the classical Jackson table. So what we have done is, we have modified our own method of doing this procedure. We are using 2 tables, both are hydraulic, which can be elevated, and we are using a plastic sheet so that the pelvic part is totally free and can be seen under the IITV. Now, you will see here 2 tables which have been spaced, and this is a plastic sheet which has been kept in between the 2 tables. Now we are going to visualize this much of the part. So the C-arm should be mobile both on this side and on the other side. Now I have placed a folded bed sheet exactly under the sacrum. Probably it is between L4 and S1 area, so that the whole pelvis is slightly lifted up. Now this enables you to get a very good lateral X-ray. The first image that you take is a AP image. Now you will see here, you are seeing the complete sacrum. This is the SI joint, This is the SI joint of this side. Now the first view that we are going to take is the inlet view. Here you have got a classical inlet view which will show you the entire superior surface of the sacral ala, the sacroiliac joints. Now this view is important. Now if you see the C-arm image, when you are going to pass your guide wire orientation has to be to this center, and this is the SI joint. So your guide wire has to be at a 90 degrees as far as possible so that you hit this area. Okay. Now from here, when we are going to take the outlet view, we are going to move the C-arm exactly in the opposite direction. Now this is the positioning of the C-arm on the outlet view. This is the sacral foramen. You are supposed to go above this. You can't violate this sacral foramen. This is a very important view that you should take when you are doing a sacroiliac or transsacral screw fixation. This is the anterior tip of the ala. This is the overhang. Now this is the iliocortical density that you see. And can you see this intervertebral remnant disc space? Your area where you are going to pass a screw is in this oval area. This is the L5 root orientation. So do not pass your screw in this area. This is a safe zone to pass your iliosacral screws. Similarly, S2 is a very safe zone because S2 you have a very large area to pass a screw. The L5 root does not come into play here. Now this is the posterior margin of the sacral. This is the anterior margin. This is the alar overhang. No screw here. This is the safe zone below the L5 root marking. Yeah. Now here you will observe that this is one line. This is the second line. Now this is the iliocortical density. They should look as one line. Because they are looking as two lines, it means that your C-arm, the beam is not exactly perpendicular to the lateral surface of the sacrum. Now if you see here, you can see one single line. This is a single iliocortical density that you see. Here we have marked a perpendicular that has been dropped from the ASIS to the floor, and the second line which has been drawn from the femur outer surface dropped as a perpendicular to this perpendicular. Now once we have done this, the first image that we do is we do a lateral image of the sacrum. This is the trocar that has been jammed into the outer part of the iliac crest in the lateral view. So this is our basic starting point. Now after having hammered this into the sacrum, I am replacing this with a thick guide wire in the same canal. And now I am punching. I have replaced the trocar with a guide wire in the same hole. Then I have passed the cannula over the guide wire, and now I am punching this cannula inside the sacrum, so that then I will remove the thick guide wire and pass the thinner guide wire out. Yeah. Now here you can see our guide wire has gone above the foramen, so we are in a safe zone. I have replaced the trocar with a cannulated drill guide, passed the 2 mm wire into that, removed the drill guide, and gone ahead into the center of the sacrum. Now I am passing the cannula for the cannulated drill, which will go over this, right? Okay. Now when you are going to do this drilling, it should be a step drilling, and at every junction you should observe for the inlet and outlet view. We are posterior to the anterior edge of the sacrum. Can you all see this?
Ready, sir.
Now this is the final seating of my cannulated drill. I don't want to cross on that side because I'm going to pass the other screw for the fracture on the right side from there, so I want some space on that side. I always call as a figure of 8 image that you see in an obturator outlet view. And remember, the inner pillar is the end margin of the screw, not the outer pillar. So this is where your final seating will take place. Stop.
I
The
think it was very well demonstrated, and only thing is there will be a lot of questions about the reduction technique which is followed. I think probably Professor Professor Dinesh can just highlight a couple of points on the various reduction techniques to be followed.
Sure, sir.
Professor Dinesh,
Yes,
are
I'm
you
on
able
the I'm on the line, but I have lost the screen picture.
you're back, sir. Sorry.
Okay, can you please tell us? You have demonstrated well about the positioning of the patient as well as the C-arm, how it has to be kept, so that what are the various parameters to be observed. I just want to know the technique of reduction of the SI joint.
There are various tools that you will require for. I'm not able to see anybody on the screen.
Sir, you can go forward. We are hearing you.
Okay.
Yeah, we can hear you, sir.
Fine.
We can hear you.
Yeah, there are many methods by which you can do this reduction, but you have to remember that if you have a posterior and an anterior injury, it is mandatory that you reduce the anterior injury without fixing it. You reduce it, hold it, go back, fix the posterior, come back, fix the anterior. Without a reduction of the anterior ring, your reduction of the posterior ring, if fixed, will not allow you to reduce the anterior part. That means symphyseal part, it will not allow. Now, it can be as simple as, tying both the great toes together. That itself can reduce a lot of reduction. However, what we do for a case where you want to get the reduction is you pass two Chance pins in the AIIS on each side, one in the iliac, the thickest part of the iliac crest. Connect both of them with the bars, and with both the hands, you compress these bars. Once you have compressed them, you lock them. So this gives you an open book closure. The other methods are when you have a vertical shear, the ilium tends to go up and towards the back. So you will have to pull this whole ilium by holding the bar that you have fixed on the AIIS and ASIS area and reduce it. What happens when you are reducing this? It becomes difficult for you to not only hold the reduction and also pass a guide wire. So what I normally do is I ask my assistant to reduce this fracture. Let us say he has got a left side SI subluxation in a vertical shear. So he stands on the same side where there is the injury. He lifts it up, that means towards the sky and towards the foot. That is how this subluxation is reduced. I go on the right side, on the opposite side, and I take a 3 millimeter thick guide wire and pass it transsacral to allow it to go and purchase on the affected side. Now that this wire has purchased, I come back on the affected side and pass the definitive wire, because concurrently to reduce from the same side and pass from the same side, it becomes difficult. The assistant doesn't understand that, and it is much easier to pass it from the opposite side. Now, in case you have a, condition where you are not really able to reduce this fracture, go ahead, take a lateral incision. You can use a Farbov clamp along with the shank pin, and that will give you a better purchase to pull on the ileum to reduce the SI subluxation.
Thank you.
Kale sir, one doubt.
Yeah.
I agree with your points on the suprastabular pin. Like I use it as well, predominantly to correct flexion extension and also posterior displacement. But like with regards to your transsacral pin, like retrieving it from the opposite side and then doing it, like does it affect your trajectory in the sense, like, because the trajectory won't be the same like when you do it from the opposite side, especially when you do a SI disruption?
No, I pass a wire from the opposite side just to stabilize the involved side. I don't use that trajectory as a wire to pass the screw.
Okay.
It is just like you are passing a K wire to stabilize a butterfly fragment.
Okay,
You
thanks.
understood? My definitive guide wire for the affected side is totally different. This is just like a wire, because see, you have such a less amount of space to operate around there. If you utilize the space for the fixation itself with your definitive guide wire, it becomes difficult to hold the reduction. These are just stabilizing wires, just to stabilize the dislocation. Left SI dislocation, assistant is pulling on the left ileum. I go on the right side. I pass a thick guide wire from the right to the left just to purchase on the left ileum. I come back to the left side. Assistant doesn't have to do anything more. Then I pass 2 screws, preferably one in S1, one in S2. Throughout this period, my right-sided guide wire is still on the patient. After I finish the S1 screw, if that guide wire is really good enough to pass a transsacral screw, which I make an attempt, then I will pass S1 transsacral and S2 only SI.
Thank
This
you.
is a good.
Thank you, Dr. Kale. I think now the time is up. Are there any questions? I could not see any questions in the chat box.
Yes, sir.
Ashok, are we allowed
I-
to ask a couple of questions in the session?
No, we have to end the session
is-
now, sir. Thank you, Dr. Ramesh Babu, sir, and Dr. Achutra for
Thank you.
this pelvis session. I call upon Dr. Praveen Reddy to take over the establishment. Over to Praveen Reddy. Praveen, my Reddy.
Yes, good morning, Ashok. Good
Yeah,
morning,
good morning.
everybody.
Yeah.
So after an excellent session on pelvic fracture management by Dr. Ramesh Perumal, Dr. Ashok Gavaskar, and Professor Kale, we'll move on to the acetabular session. Basically, first talk is on easy, fast, and reliable method to correctly classify acetabular fractures according to Letourneau system by Dr. S.G.N. Raghavendran. I would like to invite Dr. S.G.N. Raghavendran to proceed with his talk, please. Thank you.
OASISCon. I'm Dr. Raghavendran. I hope you are enjoying the talks so far. I thank Dr. Ashok Raju and the organizing committee for giving me this opportunity to present. So I'll be talking about an easy, fast, and reliable method to correctly classify acetabular fractures according to the Letourneau system. So let's dive in. Much before Letourneau's classification, several authors have proposed classification of acetabular fractures, and a few even after Letourneau. But it was Letourneau's classification which has gained universal acceptance only because of its comprehensiveness and its simplicity. So what is Letourneau's classification? We know that it has 5 elementary fractures and 5 associated fractures. The elementary fractures, what is an elementary fracture and what is an associated fracture? In an elementary fracture, there is a single fracture line, as you noticed here. Whereas in an associated fracture, the associated fracture is formed by 2 or more of the elementary fractures. And but basically, if you look at Letterman's classification, the fractures follow only three patterns. Either it's a wall fracture, or a column fracture, or a transverse fracture. So whenever you're trying to look at a fracture and classify it, it's always good that you run a stepwise algorithm at the back of your mind, because that makes you understand the fracture easily and classify it with consistency every time. It also increases, following an algorithm also increases inter-observer and intra-observer reliability. Several authors have proposed various algorithms based on radiographs and CT, but it was Moffrey et al. In 2015 that he proposed an algorithm based only on radiographs, namely the AP and Juret views. So this was the algorithm that they proposed. It's a busy slide, but we'll make it simpler as we go through. So what are the three views that you need to classify any acetabular fracture? You need an AP view and the Juret views, the obturator oblique view and the iliac oblique view. So what are the things that you need to look in an AP view? The 6 lines that you need to be familiar of: iliopectineal line, ilioischial line, the teardrop, the roof, the anterior lip, and the posterior lip. You should know what each line represents, and you should look for whether there's continuity or any breach in the lines. What are the things that you need to look for in an obturator oblique view? You need to look for the iliopectineal line representing anterior column, the lateral most line representing the posterior wall, and the continuity of the obturator ring. And sometimes the spur sign is best seen in obturator oblique views. Similarly, in an iliac oblique view, you need to look for the ilioischial line representing the posterior column, the lateral most line representing the anterior wall, and the superior margin of the iliac wing in its anterior 2/3. So once you look at these lines, the two most important lines I would say are iliopectineal and the ilioischial lines. So there are around 4 possibilities. One, the first possibility being both lines are intact. Second possibility being both lines are disrupted. And the third, only iliopectineal line is disrupted, or only an ilioischial line is disrupted. Now, coming to this, the first possibility. So both lines are intact. What does that mean? Both columns are intact. So it has to be a wall fracture. If on the obturator oblique view you see a fracture of the lateral most line, that's a posterior wall fracture. And if on the iliac oblique view you see a fracture in the lateral most line, that's a fracture of the anterior wall. Now, what is the second possibility? Only iliopectineal line is disrupted, and that means it's an anterior column, and that's confirmed in your obturator oblique view. Period. What is the third possibility? Only ilioischial line is disrupted. So that means the posterior column is involved, and depending on whether the posterior wall is fractured or not, it will be either a posterior column with posterior wall or an isolated posterior column, as in this case. So far, with 3 possibilities, we have classified 5 fractures: anterior wall, anterior column, and posterior column with posterior wall. Now, the 4th possibility, where both iliopectineal and ilioischial lines are disrupted. So, look for obturator ring continuity. If it is intact, then you are looking at a transverse fracture. Depending on whether the posterior wall is involved or not, it's a pure transverse fracture, as in this case. Or if in the obturator oblique view, if there's a posterior wall fracture, then it becomes a transverse with posterior wall. When iliopectineal and ilioischial lines are disrupted and obturator ring is also disrupted, look for fracture of the ilium. If there is no fracture of the ilium, then it's a T-type fracture, as in this case. No fracture of the ilium, iliopectineal, ilioischial lines, and obturator ring is disrupted. That's a T fracture. If there is a fracture of the iliac, iliac wing, along with obturator ring, then look for presence of a spur sign. If spur sign is present, then it's a both column fracture, and if spur sign is absent, it's an anterior with anterior column with posterior hemitransverse. What is a spur sign? So this one here is a spur sign. All it says is the acetabulum is not connected to the sacrum. Whereas in this fracture, there is no spur sign. That means part of the acetabulum is still connected to the sacrum. So this is how we classify all the 10 fractures just using AP and Juret views. And understand that 80% of the acetabular fractures are from these 5 variants: the posterior wall, transverse with posterior wall, T-type, and associated both column fractures. What is the role of CT then? So if you look at axial CT scans, any fracture through the green line here indicates fracture of the columns. Any fracture through the yellow lines indicate fracture of the walls, anterior posterior walls, and any fracture through the red line indicates the transverse component. So equipped with this knowledge, we know that you're looking at a comminuted posterior wall fracture here, and a posterior column fracture here, and a complete transverse fracture here. You can also use, you can also use the axial CTs to generate volume rendered Juret views, and the multiplanar reconstruction CTs help you with identifying final details like marginal impaction or femoral head damage. So the future of the algorithms will comprise CT scans, and then already this group in Paris, the St. Joseph's Hospital group, has incorporated has come up with this app wherein once you get a CT scan, and the app will ask you to locate where the fracture is, and somewhere after answering 2 to 6 questions, the app will tell you what fracture it is. And they have conducted a study, and they published in 2018 American JBJs, and they said that using the app there was a high classification accuracy among inexperienced groups, and also when complex fracture was involved, there was high reliability in classifying, and there was they also noticed the high inter-observer and intra-observer reliability with a significantly decreased time to classify. Of course, the app is free to download. What are the pitfalls of this study? It's purely for classification and not for prognosis. It is CT-based app. App needs a lot of bug fixation still, and the classification is not completely foolproof either. So, in conclusion, I would say you need to adapt and follow a stepwise algorithm to understand the fracture easily and classify with consistency. AP view of the pelvis and additional Juret views are still the gold standard of radiological evaluation in acetabular fractures. Axial CT images can help with the detailed analysis of fracture and its prognosis and assist in fine-tuning of classification. 3D CTs can simplify fracture classification but risks underrepresentation of fracture details. Thank you. I hope you are able to understand it. And if you have any questions, I'll be happy to answer them during the question and answer sessions. Thank you.
That was an excellent overview of the classification systems and how do we classify these fractures. So we'll move on to the next speaker. So play next video, please. The next talk is by Dr. Saji P. Thomas on decision making in acetabulum fractures, overview of choice approach.
I would like to thank Dr. Ashok Raju for having given me this opportunity. We all know that acetabular fractures have got a complex 3D morphology, and being intra-articular fractures have to be reduced anatomically. Hence, it is imperative that you select an approach that will help you reduce these fractures anatomically. We all know that the fracture type is the one that decides the approach, and hence the fracture type is decided on a standard X-ray, being the AP X-ray and the Juret views, and also gives the CT scan gives you additional information like the impaction on the wall, the intra-articular steps, the involvement of the femoral head fractures, and intra-articular loose fragments. Armed with this additional information, one can decide on the proper approach to fix these fractures. The approaches to the acetabulum, we have the posterior approach, the workhouse approach being the coccolaminal approach with or without a trochanteric flip. The anterior approach, the ilioinguinal approach, which is now being less popular because of the dissection of the neurovascular structures, the iliofemoral approach, and then the anterior intrapelvic approach, which is fast gaining popularity, and the recently developed pararectus approach. The extended approach is the extended iliofemoral approach, usually done by well-experienced surgeons because associated with high morbidity. More and more surgeons are moving towards combined approaches, which are simultaneous or sequential, which is a combination of the Cocker-Langman approach with one of the anterior approaches. The acetabular classification is basically divided into the elementary acetabular fractures, which are 5 types, and associated acetabular fractures, which are again 5 types and are the combination of 2 of the elementary acetabular fractures. In this study by Gusick et al., they have said that the anterior wall, the anterior column, and the anterior column with posterior hemitransverse, predominantly being the fracture of the anterior aspect of the acetabulum, can be approached by one of the anterior approaches, which is of the treating surgeon's choice, and the posterior wall, the posterior column, and the posterior column with wall, the fracture being predominant in the posterior aspect of the acetabulum, are well amicable for management through a Cocker-Langenbeck posterior approach. That leaves us with 4 fractures: the transverse fracture, the transverse T fracture, the transverse with posterior wall, and the both column fractures, which require additional considerations to decide on the surgical approach. The transverse fractures, we all know that the transverse fractures are 3 types. The transrectal being one of the most difficult fractures to treat because it involves a weight-bearing dome of the acetabulum. The approach selection, again, in this transverse fractures are based upon the opening up of the end, whether it is opened up anteriorly or posteriorly, whether the displacements are anterior or posterior, whether the rotations are anterior or posterior, or whether what is the obliquity of the fracture. If it is high anterior, you require a high anterior approach. If it's a high posterior, you require a posterior approach. Transverse fractures can be fixed by any one of the single approaches, provided you get the opposite column reduced well. Most of the posterior transverse fractures are treated by the posterior approach, and you can fix the anterior column by an anterior column screw. However, in certain cases like the transrectal, one may have to do the trochanteric flip or use another totally separate approach anteriorly to fix this fracture. Here's an example of a combined approach for fixation of a transverse fracture. The T fractures is one of the fractures of the acetabulum which has got the worst prognosis, and it is basically a transverse fracture with a vertical limb dividing the inferior acetabulum into an anterior half and a posterior half. And based on whether the anterior column is displaced more with the femoral head or the posterior column is displaced, and the degree of combination, wall impaction, etc., decides whether you go through an anterior approach or you get a combined approach. Here is a fracture, a T fracture of the acetabulum, again being treated with a combined anterior and a posterior approach to get anatomical reduction of the intra-articular T fracture. The transverse posterior wall fracture, the posterior wall being one of the elements of this fracture, requires a posterior approach. However, if the fracture line, or the transverse fracture line is exiting transrectally and is predominantly anterior displacement is there, one may require to do a trochanteric flip or a separate anterior approach to fix the anterior column. Also, the wall impactions will dictate the approach, whether if the wall impaction anteriorly, you have to go anteriorly. If the wall impaction is posterior, you may have to go posteriorly. Both column fractures, again, the fracture choice approach is the anterior approach. If it is a high anterior column fracture, then you may have to go with a ilioinguinal or an EIP approach with a lateral window. If it is a low fracture, one can do an iliofemoral approach to fix this fracture. However, sometimes we may have to go to along with the anterior approach, we have to do a posterior approach in case of a segmental posterior column or a posterior wall involvement along with the both column fracture, and in cases of combination with extension into a sacroiliac joint, one may have to do an extended iliofemoral approach. Here is an example of a both column fracture being fixed with a anterior approach and the posterior column fixed by the posterior column screws passing through the plate. The combined approaches can be sequential or simultaneous, but when you do a combined approach, the dilemma is which fracture to fix first. Usually it is better to fix the anterior column fracture first because otherwise if you try to fix the posterior column screws can come in way of your anterior column reduction, and hence it is better to fix the anterior column first. In T-shaped fractures, the most displaced column is treated first, and based on combination, the most committed column has to be fixed first. Disadvantage being the increased blood loss and increased morbidity, ectotopic ossification, and increased surgical time. The extended iliofemoral approach can be restricted for severely comminuted acetabular fractures, with fractures with delayed treatment for more than 3 weeks, posterior combination with sacroiliac joint involvement, and malunited acetabular fractures. In summary, choice of approaches for acetabular fractures is based on fracture pattern. The approach selected should address the major displacements, rotations of columns, impaction, and wall involvement. Local soft tissue involvement such as moral Levely lesion also will dictate the approach. Time delay more than 3 weeks will require an extended approach or a combined approach. Associated major systemic injuries such as bowel or bladder injuries giving rise to colostomies or suprapubic cystostomies may dictate your approach. Surgeon's experience and preference of approach is also plays a major role, and most fractures, one should remember, can be treated with a single approach. Thank you.
Thank you very much for the excellent talk, Dr. Sajid Thomas. We'll move on to the next talk by Dr. Saravanan Manoharan. Posterior wall fractures, everything you need to know. Play the next speaker video, please.
Good morning, one and all. Next, we are going to deal about posterior wall fractures of the acetabulum. Posterior wall fractures are very common, and they constitute about 20 to 25% of all the acetabular fractures. Though they are classified under the simple fracture category according to Jude and the Letournel classification, it has a complex bony and a soft tissue injury. The mechanism of injury is actually a dashboard type of car accident where the forces are transmitted onto the ipsilateral proximal intertarsal femur onto the posterior wall of the acetabulum, thereby fracturing it, and usually the hip also dislocates along with it. The degree of hip flexion during the impact determines which part of the posterior wall is going to get fractured. Accordingly, it could be a single wall fragment, or it could be comminuted or multiple fragments, or there could be extension onto the superior dome. To describe further, we have an illustrative case wherein the 39-year-old gentleman who had a car accident and presented to the ER with severe pain, his right hip and knee were flexed. The X-ray shows that the hip is dislocated, and along with the femoral head, there is a large posterior wall fragment which is seen in this X-ray itself. A quick neurological examination is done to rule out sciatic nerve palsy, which is quite common with this type of injury. And a CT scan should never be done before attempting a close reduction, because any delay in close reduction can increase the chances of avascular necrosis. Moreover, a CT scan in a dislocated hip is not informative at all. A close reduction is done under sedation, and then we take a post-reduction X-ray to look for whether the hip is congruously reduced or not, and describe how about the number of wall fragments, and also to find out whether there is any associated fractures or not. Here, in this case, we find that the hip is not congruously reduced, which could be because of intra-articular bony fragments, or it could be a large posterior wall which extends into the superior dome, or there could be associated fractures. These associated fractures can be either of the acetabulum or of the femoral head. Then we do a CT scan to look for incarcerated bony fragments which are stuck into the joint, to find out the morphological pattern of the posterior wall, and to diagnose marginal impactions associated with this fracture, and also to find out whether there is any associated fracture patterns of the acetabulum or the femoral head. Then this is the CT scan of this particular case. We find that the fragments are multifragmentary in this case, and we have to notice the small osteochondral fracture which is lying way behind the retroacetabular surface. The further management in this case is definitely surgical because of the incongruous reduction. If the hip is stable and congruously reduced, we can try conservative management also. Before trying conservative management, we should do a CT scan to find out the size of the wall fragment. If it is less than 20% of the normal size, then we can try conservative management. Again, we can confirm it with a examination and anesthesia to find that the hip is stable or not. The surgical planning includes the position, approach, reduction, and fixation strategies. The position, it can be done either in a prone position or in a lateral position. Though the lateral position is quite commonly used, prone has its own advantages in that the femoral head remains reduced inside the acetabulum during the procedure, and the weight of the limb does not displace the fracture fragments. And the only disadvantage is that we have some orientation issues with the fracture in the pelvis in the prone position. The approach is the Cocker-Langenbach approach. It is different from a hip replacement approach in that the gemelli and the obturator internus is cut around 1.5 centimeters proximal to that of the insertion, and the obturator externus is preserved. The quadratus femoris is preserved. With this approach, we'll be able to expose the entire retroacetabular region. But if we want to expose up to the superior dome as well, if the fragment extends into it, then we can do a greater trochanter osteotomy with this approach to improve our exposure. We have to preserve the sciatic nerve by keeping the hip in the extended position and the knee in the flexed position during the entire procedure. And once that approach is done, we need to distract the joint to remove all those incarcerated bony fragments. Then we look for the marginal impaction. Marginal impaction is nothing but an osteochondral fracture of the acetabulum which gets impacted onto the posterior column. The clue to find out marginal impaction is that none of the acetabular cartilage should be visible to us. If it is glaring at us, it means that there is a marginal impaction and we need to correct it with the help of we have to correct it, elevate it, and fill the defect with a bone graft and fix with hair wires or screws. Once it is corrected, we have to reapply the posterior wall, push it with the help of a ball spike and pass temporary K wires, and then we'll have to pass 3.5 screws in the compression mode across the fragments so that we will achieve interfragmentary compression. And we have to make sure that the screws are passed in the safe zone and they are directed way away from the cartilage. An under control plate is placed over the screws and the wall to make sure that the forces are resisted. We have to realize that when the patient is lying on bed and his hip is flexed, the entire weight of the lower limb acts on the fragments to displace the fixation. So our fracture fixation has to be solid enough to resist all these forces. If the fragments are quite small, we can use a spring plate or cut a 130 blood plate and use it as a spring plate underneath a definitive posterior column plate. In this case, we have to make sure that the sharp spike of the plate is approximate only onto the bone and it doesn't reach the bone and reach the labrum. This is a post-operative X-ray of the same patient. It shows that the hip is congruously reduced and the fixation is in the screws are all in the good position and away from the joint. The oblique views also shows that the hip is well reduced and none of the screws are intra-articular. If all these principles are followed, we get a good outcome and a good follow-up. In summary, a close reduction should always be done before a CT scan. The hip is extended and the knee should be flexed during the entire procedure. Marginal impaction has to be identified and to be corrected. Greater trochanter osteotomy improves our exposure for the superior dome. Anatomical reduction and stable fixation are paramount in this particular case. With this, I'd like to thank the organizers for providing me this opportunity, and I thank you one and all. Thank you.
That was an excellent talk, Dr. Saravanan. Next speaker is Dr. Tony Kavalakar on transfers and T fractures, the challenges in management. Play the next speaker video, please.
acetabular session. My topic is transverse and T fractures, challenges in management. For any acetabular fracture, identification and classification of fracture is very important for selecting the proper surgical approach, and also for anatomy reduction that should be less than 2 mm in all views, and also for stable fixation for getting early mobilization and a good function outcome. Transverse fracture bisect the anterior and posterior columns and divides the acetabulum into upper iliac and lower ischiopubic segments. In CT, it is sagittally oriented fracture line with the superior lateral and inferior medial at the roof level. Transverse with the posterior wall, there should be additional fracture line that separate the posterior wall into a separate fragment. Transductor fractures through the middle of the weight bearing dome having a very poor outcome, demonstrated by Damata, Lecternal, and Ganslen. In T fracture, there is a transverse fracture with the corona component. Inferiorly, disrupt the occipital ring and splitting into anterior and posterior components. Duplication of the Lewis line is a pathognomony for the T-type fractures in plain X-ray. Transductor fractures with medial displaced femoral head and displaced column is a poor prognosticator for the T-type fractures. Recently, in 2013, by Lubowski, demonstrated a bone density mapping and found that maximum bone density in posterior and superior part of the dome. So, if the fracture involving that posterior and superior part of the dome and the reduction is not anatomical, the clinical outcome will be very poor. Pathoanatomy. In transverse fracture, the hemipelvis hinges on pelvic symphysis, so rotation is not a major issue. Direct reduction with a stable base, that is symphysis, is much easier. But in T fracture, ischiopubic segment is a free floating segment, so restoring the roof and reduction of the ischiopubic segment is equally important for getting a congruent joint. Most acetabular fracture can manage with a single more limited anterior post approach, as demonstrated by Lecternal, Mayo, Helfet, and Shaggy. The selection approach is very important for T-type of transverse fractures and depends upon the direction of rotation displacement. If the rotation displacement is more posterior, better to go for a posterior Cohen-Langham approach. And if the rotation is anterior, better to go for an anterior approach modified stopper. Second is the height of the fracture, that means transductor fractures that extends superiorly and medially into the greater sciatic notch and will much near to the superior neurovascular bundle. So dissection will be very much difficult, so better to go for a trochanteric osteotomy to see the superior part of the acetabulum. Third is the obliquity of the fracture. If the fracture line from posterior to anterior, better go for posterior approach, or from anterior to posterior, better go for anterior approach, because the reduction will be much easier. The presence of impaction wall fracture also determines the selection of the approach. Dual approach is also very useful in complex T-type or transverse fractures that can be done simultaneously or sequentially. It is very useful in transductor fractures. Associated symphysis disruption or contracture will become a fracture in which the hinge will be lost. Extended posterior wall fractures. So once you decide the dual approach, which column is to fix first, that's very important. More discrete column is to be fixed first without entering the screws to the opposite column, otherwise production of the opposite column will be difficult. For anatomy reduction, different techniques are described. In anterior approach, a pin shunt screw in the neck of the femur with the lateral traction is much easier to reduce the medial subluxation. In the posterior approach, shunt screw in the ischial tuberosity can very easy for reducing the lateral displacement rotation of the posterior column. Ferbeff clamp or a web-based clamp is also very useful instrument. One thing we have to be careful that it should not overcompress at the fracture side, that it may open the opposite side. Once you're happy with the reduction, you temporarily fix with the K-wires. You can palpate the posterior column quadrilateral plate up to the anterior column. Then you fix with the anterior column screw. That should be from 2 cm lateral and superior to the acetabular margin in the gluteal pillar. So once you fix the anterior column screw, then you can fix the posterior column with interfragment screw in the greater cyclic notch or a small plate in the medial side of the posterior column. Then the classical posterior column plate from the limb to the skill tuberosity. So if you are doing the anterior approach, you fix the anterior column first, then reduce the posterior column to the anterior column with a offset pelvic reduction forceps or collinear reduction forceps. Then you check with all three views, AP view, octet oblique, iliac oblique, the reduction and the congruity of the joint. One of the examples is a 52-year-old lady with following a road traffic accident with a transverse fracture, posterior wall, neck and greater trochanter. CT also confirmed the transverse component with the posterior wall, neck of femur and greater trochanter. So the posterior wall is involved. The posterior wall is involved. Post approach is better. So we reduce the transverse component with fixed with a small plate on the middle side. Then posterior wall is fixed to the posterior column and fixed with another plate. And head is replaced with a unsymmetrical molar hematoplasty. So another case was 60-year-old boy with a T-type fracture. X-ray showed classical duplicate iliosquare line. CT also showing the transverse fracture with a T component. So the displacement medial, so anterior approach will be better. So we went through the anterior approach and tried to reduce the medial displacement, but it's very, very difficult. So we put a small plate on the infrapectineal side of the acetabulum, then put an anterior column plate. Even after putting this anterior column plate, there is a gap in the posterior column. Posterior column is not reduced. So we change the patient to lateral posterior and reduce the posterior column and put a posterior column plate. This is the final X-ray of the patient. So in conclusion, selection of approach is very crucial in T-type or transverse fractures. Most of the fracture can be managed with a single limited approach. Dual approach will be beneficial for anatomic reduction in complex transverse or T-type fractures.
Thanks very much, Dr. Tony Kavlakat. That was an excellent talk on transverse and T fractures challenges in management and nice case examples as well. The next speaker is Dr. Ramesh Sen on acetabulum fractures in the elderly, decision making and treatment recommendations. Can you please play the next speaker video? Thanks.
Good morning, friends. I'll be talking about acetabulum fractures in elderly. These fractures constitute about 14% of our overall acetabulum fractures, and mostly fall at house is the most common mechanism in this elderly age group. And we know that these patients are likely to have a lot of morbidity, so any traction is likely to increase their mortality profile. What is important in this age group is that there are likely to be a lot of comorbidities. The fracture due to osteoporosis is likely to be comminuted, and we need to have a very early ambulation in these patients. Classically, these patients have primarily anterior injuries, whether of anterior column associated both column fracture or anterior column posterior hemitransverse kind of injury due to a force coming from the lateral side, pushing the hip inside anteriorly. The kind of management, it has varied from a non-operative treatment to percutaneous to a late stage arthroplasty to a simultaneous arthroplasty and fixation of the fractures. Whatever method is preferred, the rapid mobilization of the patient and the rehabilitation of the patient, maybe sitting on the bedside, maybe using a walker, is the most important aim in this age group. But there could be patients who cannot be taken up for surgery either due to significant medical comorbidities or dementia or osteopenia, or there will be patients where the displacement of the acetabulum fracture is not significant enough to require any reduction process and the femur head is converted. These patients can be managed by bed rest with the limited movements. But traction should not be ever indicated in this age group. Other options include fixation of the fractures without replacement at some stage. But what is important in fixation is that bone quality is likely to be extremely poor, so our screws are not likely to give us a good purchase. Another issue is the impaction of the fracture, which definitely alters the outcome of these injuries in this age group. While doing percutaneous fixations, those fractures where there is not much of the displacement, the pain element, the stability element can be augmented by using these percutaneous screws. But if we have to do the proper reduction, it will require an appropriate surgery, and our stability has to be sufficiently strong enough that both primary stability as well as secondary stability is achieved in these patients. The best surgical approach, which is least morbid, will be modified stoppas or so-called AIP approach in these patients. And this is the kind of a stability we can give to these comminuted segments, which we can buttress from this approach. The benefit of buttressing is in the early rehabilitation of the patient. Early after these surgeries, the patient can be ambulated. And this is his follow-up after a year. Another patient with the same kind of a combination ABC kind of a fracture reduced and supplemented with a plate through stoppas approach. And this gives the ability to have the ambulation of the patient at 3 months, which is quite independent kind of a activity. There is another patient, he was the old age tourist coming from Spain, which incidentally had an impacted fragment into the superior dome. And when we operated upon, primary reduction was of that impaction. Once we reduced it, thereafter we put a plate in the buttressing mode, and this was his post-operative X-ray. Then he had gone to, Spain. From there, he sent his video of his ability to walk with the support and then without the support in this scenario. This is an old man, 92 years. He came to us in 2017. You can see the X-ray, and we tried to reduce the fragment, reduce the displacement, and put a plate, and it was okay, and we could rehabilitate. 3 years later, just this month, this patient again fell and sustained another subtrochanteric fracture, and we saw his hip has also displaced medially in 3 years of ambulation period. Now he was 95 years old, so we had to go in for surgery to do a replacement and a reconstruction of the fracture, and he has been mobilized again. But this kind of a alteration and the involvement of the mid-brain dome depression is common, and they do let up with replacement, and this is not uncommon. Every fourth patient may end up with replacement after that initial reconstruction. The benefit of the early reconstruction is that you get a good bone mass to do a replacement. The disadvantage on the other side is the scarring, the heterotopic ossification, or the chance of infection, which can stay in that area. So the other option comes when you have to do a reconstruction replacement in one go. One of the method could be that you put up multiple percutaneous screws and do a replacement. But we must stabilize the corridors, and we might have to do an open reduction of those columns and then do a replacement. We have to understand that this kind of a surgery will be longer because there are two surgeries. Blood loss will be higher, so morbidity is likely to be more. There could be defects which may have to fill up by bone grafting, and we need a good cup stability. If the bone is very poor, we might use a cemented kind of a cup. The dislocation rate is also higher in this age group because of the poor muscle mass, and dual mobility cup is advised. This is one of those significantly comminuted osteoporotic bone where we stabilize the entry column and then did this dual mobility cup over there. This is another patient of weak old injury. We try to reconstruct it and put a cage, and through which we applied a cemented cup in that area. This is another case which was 3 weeks old when it came to us. In this situation, our uncemented cup was very well over there, and we could mobilize the patient. This is his ability to move at 2 months, where he's trying to gain that level of a confidence in his working. So what is the outcome of these cases? The literature says they do have a reasonably well accepted outcome of doing a reconstruction and then doing a replacement in these age group patients. So what we understand in the elderly patient, how do we recommend it? If the patient is morbid enough not to be taken up for surgery, or his fracture has not displaced much to be requiring the reduction, the patient can be treated non-operatively by a limited period of skin traction for comfort level and then rapid mobilization. But if patient is functional, ambulatory, can tolerate surgery, we have a choice of doing a reconstruction if that acetabulum is reconstructible. Not much of the combination. But if it is comminution and it doesn't look to be reconstructible, we will have to plan the reconstruction of the columns and do a replacement in that scenario. Thank you.
Thank you very much for the excellent talk, Ramesh Sen sir. Let's move on to Dr. Lokesh A. Veerappa's talk on combined pelvis and acetabular fractures. Play the next video, please. Thank you.
Hello, I'm Dr. Lokesh A. V. My topic for the day is combined pelvic and acetabular injuries. So, what constitutes a combined pelvic and acetabular injuries? We know about pelvic ring fractures, and we also know about acetabular fractures and acetabular injuries, which cause the ball and socket joint of the hip to be affected. So, whenever there is fracture of the acetabulum combined with a pelvic ring disruption, which requires separate reduction and fixation, we call it as a combined pelvic-acetabular injuries. We have seen that the initial publications have encompassed all the injuries of combined pelvic acetabular injuries. There can be anterosuperior iliac spine avulsions. There may be simple pubic ramus fractures. So they were all included initially under combined injuries, but over the years, this has actually been called combined pelvic acetabular injuries only when both of them require separate reduction and fixation. We published in the Journal of Clinical Orthopedics and Trauma a systematic review of combined pelvic and acetabular injuries recently, wherein we went through all the articles from the beginning till now. And these are some of the pointers we can know about these. One is that the incidence is about 5 to 14% of pelvic injuries. Why such wide variation is because initially, as I mentioned, they used to include everything. Every small fracture of the pelvic ring, which is not constituting the stability of the pelvic ring, were included. But later it was, included as only those causing and requiring fixation. And if we see in combined pelvic acetabular injuries, the acetabulum is more of the transverse and ABC types. And the pelvic ring there is equal propensity of the lateral compression of the APC types. And the mechanism is usually continued force of implosion due to dual impact or due to dual impact, where usually the axial load is causing the typical transverse or the ABC fracture, and the continued force is causing disruption of the sacroiliac joint and pubic and bicepubic ramus disruption. So patients with combined pelvic injuries have low GCS and high injury severity scores compared to isolated acetabular fractures. The mortality rate ranges from 5 to 14%. So there is an importance of initial management. These are supposed to be managed like a typical pelvic ring injury, which has hemodynamic instability and which needs to be addressed. The patient's blood components needs to be replaced, and that is the first course of action. And of course, there is always a dilemma of reduction of dislocation with the when the mobile ilium or the mobile nominate bone is there. We have to stabilize the pelvis before we do any traction and reduction in such a scenario. So the definitive management in the systematic review, we found that averaged about 5 to 7 days after the initial injury, and the order of fixation has been proposed from posterior to anterior, that is the sacroiliac joint first, and then the acetabulum, followed by the anterior pelvic ring. So single approach is preferable, of course, mostly the anterior approach, and a multidisciplinary approach is if needed. Previously, it used to be ilioinguinal for most of the surgeries, but nowadays, with the advent of the intrapelvic approach, anterior intrapelvic approach, and iliofemoral modifications, this is combined together, usually most of the scenarios, to achieve what we require to do. And outcome, poorer acetabular reductions and residual pelvic displacements are seen compared to isolated injuries. That means to say, compared to an isolated acetabular fracture, these acetabular reductions are difficult, and also some pelvic displacement is residually seen. Typically, what are the factors affecting outcome? Increased age, a T-type acetabular fracture, a tile type C, that is vertically and horizontally unstable pelvic injury, residual posterior pelvic ring displacement, they affect the outcome. Heterotopic ossification, sciatic nerve palsy, and infection, as in any acetabular fractures, can affect outcome. So we usually try to discuss it with case-based. The first one is a 54-year-old with a road traffic accident, male patient. We see that there is a disruption of both the ilioischial and the iliopectineal lines, and there is pubic symphysis disruption, sacroiliac disruption on the left side, and also the obturator foramen is disrupted. So typically it falls to the T-type fracture category. The head is medially displaced, and also there is sacroiliac joint injury. And the same thing can be seen in the axial cuts, as we see here, the disruption of the sacroiliac joint seen along with the fracture of the acetabulum. So how do we deal with this? The first, we actually treat it like a pelvic injury. We actually hemodynamically stabilize the patient. We use a pelvic binder. We can actually use, you know, typically an external fixator initially if required, and we may actually have to do pelvic packing also in some instances, but not in this case. We did not do that. We actually used a pelvic binder initially and hemodynamically stabilized the patient, and we put the patient on upper femoral, distal femoral traction, skeletal traction. And what is the preferred approach and what is the order of fixation? As I was mentioning, we start from posteriorly, sacroiliac joint is fixed, then the acetabulum is fixed, and then anteriorly the pubic symphysis is fixed. And does one fixation affect the other? Is it does. If we fix the pelvis completely, it would be very difficult to fix the acetabulum. So sacroiliac joint is fixed, and we have some leeway to fix the acetabulum, and then we fix the pubic symphysis. So that's the CT scan, which is showing the same. And we have the anterior and the posterior views of the same thing which we talked about is being depicted. So we did do the same thing. We actually tried to do close reduction, stabilizing the ilium, and anterior approach was used to address both injuries, and the pelvis was fixed first. That is the posterior sacroiliac injury. So this is what we did. We did anterior fixation of the sacroiliac joint with plating. Along with that, we usually used a single iliosacral screw, because we were not happy with the initial fixation along with the plate only. And the iliofemoral approach was used for that, and the anterior column was reduced, and we used the anterior intrapelvic approach, AIP approach, to reduce the pubic symphysis and the anterior column. And we could not achieve good reduction of the posterior column, so we actually went ahead with the posterior approach and fixed the posterior column also. So that's what we see, uh, the views, the inlet outlet views, and the AP view. This is another injury wherein we see what is called anterior column injury, sacroiliac joint disruption, and pubic diastasis. Typical combined pelvic and acetabular injury. So what we did is we actually used a single iliosacral screw to fix the sacroiliac joint, which was partially disrupted only, and we fixed the ilium, and we actually went through an anterior approach, and we used interfragmentary screws. We used the magic screw to fix the medial part of the sciatic buttress to the lateral part from the AIS, and we used the in-out-in screw, and we used the anterior column plate, and we could achieve all these fixations here. The third patient is a bicolumnar fracture, 59-year-old male road traffic accident, and then so this is how it was, and this is what we did. The only difference is that we actually used a posterior column plate through the modified STOPA or the anterior interpelvic approach, and we could achieve this fixation. So that's 4 months post-op. So typically, combined pelvic injuries have low GCS scores. Early management is similar to pelvic injuries, and posterior pelvic ring should be done first before acetabular fixation. Anatomical acetabular reduction is critical, but minor malreduction in pelvic ring is okay. Thank you very much for your patient hearing.
Thank you very much, Dr. Lokesh Virappa. Time for some questions now, please. If anybody has any specific questions, Ashok, you want to take over?
I think we have around 5 minutes for discussing. If anybody has questions, I think they can go ahead. I have not got any questions.
Okay, if you can discuss the salient features on the next session on basically case scenarios, probably that will be more beneficial.
I think we should, if everybody says yes, I think we can start with the case discussions. That is more interesting. Yeah. Give me a moment. The organizers have to share my screen because give me a moment. I'm unable to share my screen, but I think, yeah, fine, take. Hope everybody can see my screen.
Yes.
Yep. Let's start with the first case. We have talked about the resuscitation. So the first case will be a polytrauma. There's a 28-year male who met with an road traffic accident and was referred to our hospital. He had come within 5 hours of injury. On examination, he was drowsy, but responding to our verbal commands. His chest compression was positive, and his breath sounds were less on the right side. His abdomen, we are not very sure. There was some kind of guarding. Bowel sounds were less. Pelvic compression was positive. Catheter, which showed some amount of, it's predominantly urine, but some amount of blood in the urine was there. We log rolled him. We found that there was no wounds or injuries. The spine clinically was normal, and no other limb injuries were seen. So we have, his pulse was around 140. His respiratory was 34. His BP was 90/60. So the question to Dr. Perumal, so what do you think the patient is in?
Yes, this patient is having classical polytrauma with pelvic injury with a hemodynamic instability.
Yeah, so he is hemodynamically unstable. He's in hypovolemic shock. So what will you do?
Shock, and the investigation shows serum lactate and base deficits are abnormal with low saturation.
Yeah.
This patient has to undergo a damage control resuscitation. First, since the pelvic compression test is positive, I just want to give him an pelvic binder, as it gives a circumferential compression. And then, as you all know, in a polytrauma, the anesthetist is the team leader.
Yeah.
So we'll involve the anesthetist, and then we have to start him on a damage control resuscitation. So by the time we start them on crystalloids, we normally used to give a normal saline and ringer lactate, whichever is available at the moment. We start giving them up to 1 liter. And then the moment we got the blood test, we come to know about the blood group. So we get them as per the 1:1:1 ratio. We arrange for the adequate amount of blood products and whole blood. So we used to give them the resuscitation along with the blood products.
Okay.
So when the resuscitation is going on, in the ER room, so both our the radiologists will come and do a fast. So look
Okay.
for the fast which focus on the source of bleeding, where it is in the intra-abdominal thing or not. We can do a fast test, and then we look for an examination of the exposure examination of the suspected injuries. So at this point of time, our aim is to focus on look for concealed injuries and resuscitations.
Yeah. So I think as Dr. Parumal said, he's in hypovolemic shock. So we do all things simultaneously. There is no you get a line, you send the blood for investigation, and at the same time you start fluid resuscitation. That is done from one side. At the same time, somebody is applying a pelvic binder to, because your compression, pelvic compression is positive. So how many lines would you like to have?
At least two. At least we give it 2 lines.
2 lines. What gauge needle?
Probably.
Pardon?
16 or 18.
Yeah, I think 16 is a little difficult in Indians, especially when they are in hypovolemic shock. 18 also is a good option. The smaller the gauge of the needle, the less amount of fluid is going to go through the through that small radius of the cannula. So what is your fluid? I think you have already explained about your fluid challenge. So, but your talk has said that you would like to give 500 ml of fluid over a period of 5 to 10 minutes. Is that hold good for you?
Yes, but at least 500 ml to 1000.
Yeah. What would be the fluid protocol for other panelists? What is your fluid challenge protocol? Dr. Saji, Thomas?
Yeah, Ashok, my challenge, mine would be the same thing like what Dr. Paramala said.
Yeah.
And we would also, in additional to that, because our anesthetist is taking care of the resuscitation, we put in a CVP line to monitor the fluid challenge, whether it is responding or not.
Okay.
And also keep an indwelling catheter to see whether, if it is possible, if there is no urethral damage, then we put in a indwelling catheter to see the urine output also.
Okay. Any change in the fluid challenge management from the other panelists? Okay. So coming to pelvic binder or an X-fix, how many people use an X-fix in the casualty now?
We use it.
Okay. So
But in the casualty,
in the casualty,
you mean you put a X-fix right in the casualty? After
No, sir. I was saying the pelvic binder, not the X-fix. Sorry.
Oh, okay. Yeah, I think before as a resident and as a registrar, I think the first time what we learned was to put an X-fix. It was a blind procedure. The iliac shan screws were put, and we used to put a X-fix. But now I think almost everywhere the pelvic binder has the same control. The in fact, it is better than the X-fix, even for transportation. So I think the pelvic binder is the most important thing now. So would you use a commercial or a bedsheet technique?
We prefer a bedsheet. We do a bedsheet. We don't very rarely use a commercial one. We use the bedsheet.
Yeah. What
To be
would
honest,
be?
I have not seen a commercial one.
No. What?
No, I'm just
What?
telling you.
Yeah. What this is? What we get the patient most of the time is the lumbar corset, which is tied around the abdomen level, and they come with that as a pelvic binder. So, what would be the level of your application of the pelvic binder? What
It
would
will be the
yeah.
trochanteric level.
Yes. So the center of the pelvic binder should be at the level of the trochanter. Would you
And
tie
second
an
thing is tie both the feet, the great
Yeah,
toe.
yeah, yes. That
yeah
is.
yeah? Would you tie a knot or would you put a clamp?
No, we put
Uh, we put clamp.
Yeah. So what we have realized initially, a lot of people used to pull on either side and tie a knot around the symphysis. I think that is not required. You don't have to use too much force. What is very important is to get the pelvis volume lower, get all the fragments stabilized. So I think a clamp would be a good idea. Yeah, if your injury permits, I think you can even tie your knees and both the fit internally and stabilize it. Once you have taken an X-ray and you realize it's a lateral compression injury, would you still continue to use a pelvic binder?
In lateral compression, 3 type I would still use, but 1 and 2 no.
Okay, yeah. In the resuscitative phase, I think it doesn't matter what type of pelvic injury it is. It is only as a initial protocol. Doesn't matter what kind of whether it is lateral compression or vertically unstable or open book injury. I think pelvic binder is a must at the resuscitative type. Yes,
Yeah,
in a
yes,
lateral
Ashok,
compression.
because
Yeah.
the pelvic binder has to be applied even before you take, if you suspect a pelvic injury clinically, before the
Hmm.
X-ray is taken, you should ideally put in a pelvic binder.
So, so
So,
after
so
it
you
is
so you may not be able to diagnose whether it is a lateral compression or not, and you may have a pelvic binder. You have to put a pelvic binder, whatever the injury initially, to resuscitate the patient.
so you know that the patient is hemodynamically unstable, and then you know that he is having a lateral compression injury. Then would you remove it in lateral compression type 1 and type 2?
No, if it is
You would continue.
hemodynamically unstable, no.
Yeah, you would continue to use it.
Yes.
Yeah. And how long would you keep this pelvic binder?
We usually wait till at least if you have to do if the patient is hemodynamically stable and if you're planning to put an X fix, then we go and put in an X fix and then only remove the binder. And
Yeah.
ideally, it is not advisable to put a long duration of binder because it can create pressure sores.
Yes.
No, but if the patient is hemodynamic stable, would you not advise for a CT to be done? Because without the CT, you are, I mean, it's difficult to say. Because, when do you get the CT done? Tell me that.
Sir, once the patient is hemodynamically stable, then and then only we will take the patient for CT.
Yeah, so you have put a binder. You
Yes,
will
sir.
do a CT and then an X fix, or you will do an X fix then a CT.
I think we will do a CT and then an X fix.
Okay, fine.
Yeah, I think the pelvic binder continues to be there as long as the patient is hemodynamically unstable. I think you should continue till he becomes stable. That is what is my this thing take home. Only thing is that you should be very careful about if it is being kept for more than 6 hours. I think you should check for the bedsheet marks or the pressure marks which can happen on the thing. If the patient is unstable even at 6 hours of your application, that means he has to have some other form of he's a really unstable patient and he needs to be shifted to the operation theater to uh, either do a pelvic binding or for a laparotomy to see if something else is bleeding meantime. Okay, this patient is responding to your fluid resuscitation, but he's going becoming hypotensive again. We have started him with the blood and blood products. So would you get a bedside x-rays or a fast or a CT scan?
better to do bedside X-ray and fast. CT scan, no. If he is hypotensive, it would not be appropriate to do.
No, he is getting, yeah, the controversy still exists, but with the newer CT scan, which take less than a minute or 2 minutes, I think to know what is happening, CT scans are being recommended of late. If you have a setup which can really take up, you can look after the patient very well. At the same time, your resuscitation is very good, and at the same time, your CT scan is nearer, and you don't have to shift to a longer distance, and it gets over in a matter of 2 minutes. Fast is if you have a very good radiologist. I think that is when, or a critical care person who will be able to tell you. Then again, I think fast is recommended, but not all centers have this fast technique where they can recognize the injuries very well. Your take, Dr. Ramesh?
In our hospital, we have a system when there is a one from our patients come to an ER room, we have a separate trolley. So the trolley can take the X-ray cassettes down. It is a transparent
Yeah.
trolley. We can take the X-ray cassettes down. That is number one. And number two, we have an critical care physician like anesthetist will be tapped onto the patient. So that patient will be doing a resuscitation, and as a part of the thing, we have an ultrasound machine in the ER room itself. So by the time the resuscitation is started by the friend of an anesthetist will start the thing. Another one who is going to take care of the patient with an anesthetist will do a fast. At the same point of time, the X-ray cases will be driven into the patient's, particularly the chest and the pelvis.
Okay.
The moment resuscitation is going on, the mobile X-ray unit will come and take a chest X-ray and the pelvis X-ray. In the pelvis X-ray, we can see the gross understanding of the fracture pattern, like an APC injury or a vertical shear. It gives an broad idea. By the time, within half an hour time, we get the blood test done, the basic X-rays, and the anesthetist will do the fast. So by the time we get the hemodynamic stability, when the patient is kind of this kind of thing, the anesthetist will go with the patient for a CT. That's what the resuscitation is going continuous, and the anesthetist will be with the patient the moment he goes to the CT scan. If he is really hemodynamically unstable, he will take him to the operation theater with the basic X-ray of the pelvis, and also the fast positive means that he might be having a chest injury, or an abdominal injury, or a pelvic injury. So,
Perumal, do you advise your anesthetist to intubate patients who are, in spite of your pelvic binder and who are dropping down?
Exactly, sir.
Because it is better to intubate in this stage than when the patient becomes unconscious.
Exactly, sir. We have also intubated the patient and shifted the patient to CT scan with the anesthetist.
Because this movement of the patient and the time gap between you shifting the patient to the CT room, if the patient has got some bleed inside or if he's got a chest injury, and that time for a single anesthetist without supports from his colleagues to intubate becomes a Herculean task.
Yes, sir. That's what we do. If the patient is really going unstable, we intubate the patient. With the intubation, the anesthetist go with the patient for a CT scan.
Yeah,
I do understand.
Yeah, I think
in the casualty, do you do a 4-quadrant aspiration?
No, sir. Aspiration we don't do.
No. See, Ganga, I'm not talking of scenario of Ganga Hospital. You are in a periphery center, and your higher center is about, say, 2 hours far away.
Okay.
And you want to be deadly sure that okay, intra-abdominal could bleed nahi hai. I mean, if it is there also in that center, you can't do anything. But as a general surgeon, what we were taught many years earlier, at least 4-quadrant spinal needle aspiration, is it useful? Does it throw any light?
Even if it is going to be positive, if the patient is not able to manage at that center, it is better to transport to the nearby center. So even if you are going to get an aspiration, what is the next step?
Yeah, but at least now he can inform the higher center that yes, there is some intra-abdominal bleed and he's bleeding some organ has been injured. At least this information he can inform.
My personal opinion is by the time you receive the patient peripheral center, it is better to arrange for a safe transfer to the nearby center.
Agreed. Okay. Okay.
Yeah, I think.
In my PowerPoint, I showed one example of a patient. That patient actually was intubated and shifted to whole body CT scan. And patient was came back, he underwent a laparotomy and the bowel injury was addressed and then pelvic external fixator and the pelvic packing was done.
Okay. So if the patient is responding to your resuscitation, I think you can go ahead and do a CT scan. If it is an extremist case not responding, I think you have to take a call on shifting him to the theater based with if you have a good radiologist who can say, yes, there is fluid in the, there is a problem with the abdomen, there's a problem with the chest, not responding to your resuscitation, I think you can shift him to the theater without a CT scan. Yeah.
Well, let us take a scenario. The patient is bad. The general surgeon has said, yes, let the splenic tear is there, some intra-abdominal, forget CT, shift him into the OT. The advantage of shifting into the OT is at least you have an IITV there. So the IITV can show you, I mean, in general, major injuries to the pelvis and acetabulum.
Yeah. Yes, I think it is well taken, but in an actual scenario, number of cases which are extremely, which do not respond to your resuscitation are very few. So the decision has to be tapered according to your setup.
Yeah.
And your availability of your things. I think the extreme cases who don't respond, I think it is hospital-based protocol. Personally, I feel that we should, if he's extremist, you should not waste your time in shifting him to the CT. You should shift him to the theater.
Yes.
Yeah.
Agree with Ashok.
Yes. Okay. Patient is intubated. He's being resuscitated and he's kind of responding but going back. A CT scan shows pelvic open book injury, but I think it is rotationally unstable, not vertically unstable. If you look at the CT chest, there is absolutely no right side lung. He has got a huge hemothorax with a collapse of the lung. The abdomen shows a splenic rupture, lacerated liver, diaphragmatic rupture, ileojejunal contusion, and hemiperitoneum. On the pelvic side, CT shows no bladder rupture. There is on further screening from the radiologist says that there is no blush at the level of the internal iliac vessels, but there's a retroperitoneal hematoma. And there is a B positive. By this time, we have got his blood group and he's a B positive blood group. So what will you do?
The surgeon is going to take a laparotomy,
Yes.
vertical incision. Am I right?
Yeah.
You have shown the picture directly.
So before,
Chest tube.
Yeah. So the first thing is chest tube. So I think before we did, patient went to a CT chest. Already the chest tube was pushed because they could not hear any breath sounds on the. So we did not wait till the CT to get a CT done, nor the X-ray. They just have directly put a chest tube in the right side. These are all resuscitative measures which have to be done simultaneously, and decision has to be taken immediately. He was shifted immediately to the theater. They've done emergency laparotomy. They've done a splenectomy. There was some bowel injury at that level, so they have done a resection and an ileostomy, and they also have done a diaphragmatic repair. So in the same setting, the actual plan was at the time when he was being shifted to the theater to put a X-fix or through the supraacetabular pins. Because there are two tables, one is an orthopedic table which is totally radiolucent. The other one is a general surgery table, which they prefer to have a general surgery table than our table. So they were not. So he was shifted to their table. So we could not. They because we need to have a operator outlet view for XFix application. We went ahead and directly plated the anterior pelvic ring. So the posterior ring is shut. This is done through a blind. We did not use a C-arm to plate the pubic symphysis.
So do you
So
see, cubic symphysis is fairly is such a large laparotomy system. I think
yeah,
what you have done is right because you don't really require a CM for that thing. At the max, you may pass your screws 4 to 5 millimeters less than your expected length.
yeah. So but we planned for a size screw fixation much later. But after 20 days, the patient succumbed to his chest infection.
So sorry.
He became far better end of fifth day to seventh day, but from the 10th day he started deteriorating. His lung infection somehow the critical care people and the pulmonologist could not save him because of the lung infection. Yeah. So this is the scenario of a case of a polytrauma. So let's go to the second case. 45-year-old obese, hemodynamically stable patient had come to our casualty. So this is the X-ray. What would be your plan? Dr. Lokesh?
Have the CT.
Yeah. The description indicates that there is a posterior component. Even the 3D scan shows that sacroiliac joint is
Open.
extended on the side. Uh, so we would actually reduce the initially, of course, pelvic stabilization we do and all those things. Definitive fixation I am talking about. Fix the pubic symphysis and do iliosacral screws. Yeah.
So
Fix
when
the
do you
pubic
consider?
symphysis or hold the pubic symphysis because here this shear is vertical also and it is posterior also. If you fix this right now, your SI reduction will never come
Yeah,
in
yeah.
your
Always we hold the pubic
yeah.
symphysis, put the SI screw, then do the plating of the pubic symphysis. I do that always. Yeah.
No, Lokesh, this was not meant for you. This was,
Yeah.
this was a hint meant for the listeners.
Yeah. So this is, if you look at the X-ray, it is very clear that it is an open book with a vertical translation, unstable pelvic right hemipelvic injury. So based on that, we have applied a pelvic binder and gave a longitudinal fracture. And for a definitive procedure, we wanted to have a CT scan to avoid missing any other posterior injuries. Generally, on an X-ray, your anterior injuries are well defined. We can assess it, but most of the time, the posterior injuries sometimes, most of the time, it is well diagnosed only through a CT scan. So what has happened when we applied a pelvic bender and gave a longitudinal traction? If you look at the CT scans, your SI joint is almost reduced. So I think what is very important, just don't look at your CT scans alone. Whenever there's a pelvic binder, especially in rotationally unstable and vertically stable injuries, your pelvis might close in an open book injuries, and your CT images might give you a wrong picture that your posterior injury is well reduced. So I think it's clinical acumen that yes, the pelvis is opening up or closing up. That gives you an idea of what to do further. Yeah, in this case, the X-ray is more clear than your CT scan.
So
But if you look
one
at the
question,
sections,
Ashok,
sir,
you have taken the CT with the binder.
yeah,
Okay.
mainly it's
Now,
a fraction, sir.
No binder on that yet.
Yeah, binder
Binder.
binder लगाया था सर, बाद में
No. My question here is, you have reduced the fracture, put him on a
yeah,
binder, sent him to the CT.
yeah,
Now the CT shows that practically nothing with the SI joint.
yeah,
But your X-ray did show that there is an SI involvement.
yes
My
sir,
question to you is, when you shift him into the OT for bending and draping,
yeah.
will you remove this binder or will you cut open the binder, make enough aperture to pass the at least guide wires in the S1, S2, and then remove the binder?
I will I will remove the binder. I know that I'm going to get a good reduction just by
You got my question.
pardon sir.
You got my question.
Yeah, you don't want me to remove the binder.
No, I would sacrifice the cloth. I will cut open the cloth, clean it that area with spirit betadine. I am not taking a incision. I am going to pass two guide wires in S1, S2, and then remove the cloth and do the painting. Is it right or is it wrong?
No, I will not take it as a point because my CT scan shows that it's well reduced. By the time I go to the operation theater, I'm not sure how my SI joint is. So I will get into a inlet view and outlet view. I will not depend on my image nor the binder at the level of the
No, agreed,
theater.
agreed. I'm not saying that. You take him into OT,
Yeah,
you see the inlet view, outlet view, take a lateral view, all is correct.
yeah.
But will you open up the binder for washing, painting, and draping, or will you utilize this situation to
No,
pass?
I will open up, sir.
Okay, fine.
Yeah. So what would be your reduction technique? What would be your reduction technique in the theater?
I think this probably would reduce if you have, gone open and clamp the surfaces with your hands itself. This would be reduced. Maximum you will require one pin on each side in the AIIS. That should hold the reduction.
Yeah. So there are components like the fragment, the hemipelvis is cranially migrated. It is posteriorly migrated. It is laterally displaced, and it's an extension, and it is externally rotated. So how do we correct this? The cranial migration.
The
Yes.
traction.
Okay.
Tell me.
The table, along with that, we also the tracking table beforehand, so that leg is attached to the longitudinal, and usually typically we give it in around 30 to 40 degrees because that is the axis in which the next is we use the champion in the iliac crest to maneuver that, and also use lateral pressure so that the lateral displacement is superior. These things we use. One is longitudinal traction that the joystick holds the iliac, and also lateral pressure used with a ball spike or something, because there will be otherwise gap to rotate it. Anterior closes means posterior closes anterior. So lateral pressure also.
Yeah.
Yeah,
So
probably here is the same situation which Gavaskar had asked me. You put a shunt spin in the AIIS, put a shunt spin in the thickest part of the iliac crest, connect it with two bars. I don't like to put a shunt spin in the crest and pull, because many times our thickness of the crest is so bad that the whole shunt spin walks out while giving a traction. Once you have a cross bar attached, then you hold that bar and reduce the T at the reduction position. Now, in this situation, I have also found it advantageous to take a lateral window and actually visualize the SI joint, or at least palpate with the finger. And then you fire in a guide wire. Let the guide wire go wherever it wants to go and hold on the sacrum. Either from the opposite side, or if you are not used to it, fire it in the S2 so that your S1 is vacant for you to do all the fixation. Now you come back and do a proper S1 guide wire fixation.
So So which one will you fix first, the symphysis or the posterior SI joint?
SI joint first. We reduce the pubic symphysis and hold it with the
Yeah.
clamp. We fix the posterior, then we fix the anterior.
Yes. If it is a type B and fractures where it is only rotationally unstable, I think by just closing the symphysis,
Yeah.
I think even your SI joint gets closed up very well. In those cases, it is your choice of fixation, whether you want to do anterior first or posterior, it's your choice. But in type C, where there is vertically unstable injuries, I think you reduce the symphysis, but you fix the SI joint first and then come back anteriorly and fix the symphysis. So this is a case where we have put the screws we have reduced it, we have put the plate in place, we have put the screws, but we have not tightened up the screws. If you look at the SI joint there, it is still opened up, it is not reduced. So we have gone ahead and then a posterior fixation first through the screw. This is a SI joint dislocation. So what would be your direction of the screws in SI joint, Dr. Dinesh sir?
Yeah, in this here you will be going far more posterior, inferior to anterior, superior. You will not go at right angle because if you go at right angle, you are going to cause up opening up behind. You are going to put a lot of
Yeah.
strain on your symphysis. All of us have attended Saji's talk in Bhubaneswar,
Oh,
where he said in such cases where there is a vertical tear and posterior migration, guide your screw more from the floor to the umbilicus. I mean,
okay.
I'm not able to describe it exactly. Normally, our screw, I'm not talking of transsacral trajectory. We are not considering transsacral trajectory. Your hand should drop down when your entry is there for the sacrum. So you are going more posteriorly and fire it up towards the sky so that you come out in such a way that the sacrum closes more posteriorly first, and then the second screw will help you to stabilize it.
Okay.
Yeah. So you're saying, sir, basically, shall I add to that? You're saying stay perpendicular to the plane of the sacroiliac joint.
Yes, yes. It is for this reason that you require your buttocks of the patient to be little off the bed. Otherwise, your handle and your hand will hit the table and you will not get the trajectory.
Yeah. Uh, To summarize, first of all, for the trajectory of SI screw, which has to be from posterior to anterior, from caudal to cephalad direction. In an inlet view, it should be from the posterior to the anterior, and in an outlet view, it should from the caudal end to the cephalad end in an outlet view. For this, because your trajectory is you need your drill direction to be from posterior to anterior, the prerequisite is to put the patient on an elevated folder, elevated bed sheet, so that the pelvis is much higher up and you can direct your drill from posterior to anterior. That is what Dr. Kale sir is explaining about. Your pelvis should be much higher at a higher level on the table than at the table level. Otherwise, you will not be able to direct your drill from posterior to anterior.
And
So,
also the patient should be placed as lateral as possible to the table, towards
yes,
the outer edge of the table.
yeah,
Not only elevation, but also towards the outer edge, so that you
yes,
can get the angle.
yes, very true, Dr. Saji. This is what we have done we have put a screw from posterior to anterior. That is the direction of the screw. And if you look at it, as we tightened up, the SI joint is well reduced, and the Outlet view shows that the direction of screw is from the caudal to the cranial aspect. Uh, what would be your length of screws?
This is a different case.
Now, this is a different case. I just wanted to talk about the length of the screws.
See, if it is an SI screw in averagely, let us say 5 feet 9 inches healthy male, SI screw should be around 18 max. And if
Yeah,
it's a transsacral, it can go to 140. Now here, on the left side of the screen,
yeah,
that screw must be around 100.
yeah. So what I mean is I didn't want to have the length. What is
See,
very important
I
is
think,
to cross the midline.
yeah, in
Yeah,
the SI joint fixation, you have to cross the midline. And if it's a fracture, I think it's better to go all the way to the opposite
yeah,
side.
very true. So what I actually mean is not the actual length of the screw.
Oh, I thought you asked me.
No, no, sir. What is the whole purpose of it is to see that your screw, this is the midline in an outlet view. It should have crossed the midline. And in inlet view, this is the midline. So it should have crossed the midline. That is the main purpose of asking this question. Yeah. Now coming to how do you assess you have achieved accurate adequate reduction of the symphysis? How sure are we that yes, I have got a good reduction of the symphysis?
On table or post-operative?
On table, sir.
Okay.
Before you fix the symphysis. Anybody?
Typically, I run my finger on the pubic aspect of the um, pubic, the space of Retius.
Yes.
Thing is, they should be in the same plane and well opposed. And
Yeah.
also, see, once you tighten the screws, automatically the height adjustment automatically happens. Up and down, it becomes equal. But the rotational plane, we can just check the posterior aspect of the, we just pass a finger.
Yeah.
Or the inlet view.
Yeah.
So, have you ever passed the most central screw on the opposite sides?
Not yet, sir.
Because
Till
books
now.
describe that.
Yeah. I think I will leave it to cases where I have to do a kind of a revision surgery. I think in those cases, I would utilize the concept of sending the screw from from the left of the symphysis to the opposite the side inferior ears, uh, uh,
I have tried this for
ramen.
our
Mm,
patients. Our
mm,
symphyses are so small that if you pass from one symphysis to other, the second screw on the other side starts hitting the screw. The
yeah,
European pelvis are big.
yeah,
Our pelvis cannot take that.
yes. The yes, sir. The whole purpose of giving this slide is yes, as Dr. Lokesh said, you have to you can palpate the posterior aspect of the symphysis to know if there is any posterior or anterior translation, and if they are in line, I think that would be really good. But in your imaging, what you have to look at in an inlet view is that the superior pubic rami of one side and the opposite side should make a smooth C, and the distance between both the symphysis should be almost equal. There should be no step at these lines. And in an outlet view, the distance, the symphyseal distance, the joint should be equal on both sides, and both the inferior pubic rami should form a smooth curve, like a C curve at this level. There should be no step at these two levels. That is how you are going to determine that you have got a good reduction of your symphysis. Whether will you use a dual plate or a single plate. For a symphysis fixation, would you
Single.
use a dual plate or a symphysis? Dr. Saji?
If it was just a simple symphysis, I would use a single plate.
Yes.
But if it is a vertical shear with a symphysis opening, I would preferably use a dual plate in a 1990
construct. So, yeah, a 3.5 or a 4.5 system?
3.5.
Okay. Have you ever used a locking plate for this symphysis fixation?
No.
No, you would not like to. Okay.
No.
Yeah. Would you use 2 screws in the SI joint or 1 screw at the SI joint?
It again depends on the degree of SI joint involvement. If it is
Yep.
associated with the vertical, if it's just an APC 1, so 2, I would just put maybe 1 screw, but otherwise, preferably with a vertical shear, 2 screws.
So with a vertically shear, with the 2 screws in the SI joint, would you still do a 2-plate fixation for the symphysis?
No, 1 plate.
Yes, symphysis. What would be your direction of the screws? Would you
Convergent.
Yes. Okay.
Pre-contour the plate.
Yes. Will you contour the plate according to the symphysis? Over contour?
No, I usually try to just leave the plate in the, if I get a good position on the symphysis, I leave it, otherwise I contour it. And as Lokesh said, as soon as you're tightening the screws, the fragments get lifted up to the plate.
Yeah. Yeah. Yeah, I think those are indirect reductions of your finer readjustment of your reduction through your plate technique.
Yes.
Yeah. I think this is what we have done for the case what I have shown earlier. We have put 2 screws into the SI joint and then did a 3.5 system plate with screws into 6-hole plate, 3 screws on either side. The screw lengths are generally between 50 and 55. The first 2 screws on either side of the symphysis. If I get a screw which is less than 45, I would think twice about the direction of my screw. Longer the screw, longer the pull-out, the greater the pull-out strength. And my last 2 screws will be generally around 28 to 30. Any other comments?
The only scenario
I have found
is
not
when
to
I'm
use the
revising
drill
a
bit.
fixation or
Dr.
when
Lok.
I'm doing a old surgery, old few months old. Otherwise, if you do good postal fixation, anteriorly 1 plate is enough.
Yeah, point taken, Dr. Lokesh. Dinesh sir, you wanted to say something?
In the symphysis, I have found it more probably useful to use a 2.5 K wire and then fire the screw than using a drill bit, because the K wire doesn't cut the threads, and now your screw cuts the threads and has a good hole. Because one wrong trajectory, the next screw is losing your hand.
I couldn't get you because I could not hear you well.
Okay. When you are drilling for your 3.5 screw, can you hear me?
Yeah, now I can hear you,
I
sir.
don't use a drill bit. I use K wire to drill the path.
You're there, sir?
I'm there.
Yeah. Couldn't get your point.
When
But
you are putting the screw for the plate.
Ashok, he is saying use K wire instead of the drill bit.
okay, point taken. Yes. Yeah. Can go to the next case. Yeah. So, Dr. Raghavendran is there?
Yeah, Ashok, I am
Yeah.
here.
Yeah. Now I think it's your chance for the diagnosis.
Okay.
Okay.
All right. So, like I said, you see both iliopectineal and ilioischial lines are intact. So, which
Yep.
means the columns are intact. So, look for any wall fracture, obviously, if we have an obturator oblique view, we will know if there's a posterior wall. And then if we have an iliac oblique view with a fracture, it has to be anterior wall. So do we have Judet views on this?
No, you don't have Judet views. Okay.
Well, I'll go with posterior wall, the way it looks.
Yeah, the way it looks, yes. Can I run through the thing once?
Yeah, sure.
Yeah.
Yeah.
Yeah. Okay. This is how we can go. The first line, this is the algorithm, which is very useful with a simple AP view of your pelvis. I think you can come to diagnosis largely 90% of the times what fracture it is. So the first line you have to look at is the iliopectineal line. Because the iliopectineal line is intact, it cannot be an anterior injury or injuries having both uh, anterior and posterior injuries. So you exclude the anterior wall and the transverse fractures and both column fractures. So you're left with only three fractures, that is posterior wall, posterior column, and the posterior wall with the column fracture. Now your next line is the ilioischial line. So here the ilioischial line is intact, so it cannot be, you have excluded previously these things. Now you exclude the posterior column and the posterior column with the posterior wall. So you are left with only posterior wall fracture. Through this algorithm, you are the diagnosis is by exclusion. So it's a little tricky to understand if you're a beginner, but once you get a hang of it, it becomes very easy to understand. And this triangular fragment is pathognomonic of a posterior wall injury in an AP view. So once you have diagnosed yes on an X-ray, what would you like to do?
So based on once you have an X-ray,
Yeah.
yeah, obviously I would try to confirm it with a CT to look for the finer details, whether there's any infection or intraarticular fragments, that kind of stuff.
Yep. Fine. So this is the CT images you have.
Trying to see.
Yeah.
So
your diagnosis is confirmed?
Yes,
Yeah,
it's
your diagnosis
posterior superior. The fragment is posterior superior.
Yeah.
And there are some intraarticular fragments as well.
Yep.
So, yeah. And then with regards to head, can't really exactly see if there's any. There is marginal impaction, but I cannot comment about. Yeah. So
Dr.
there is marginal
Sarvanan,
impaction, intraarticular fragments, and the fracture is posterior superior.
Dr. Sarvanan will be really unhappy taking a CT scan without reducing the hip.
Yeah,
Dr.
actually,
Sarvanan?
yeah. See, this doesn't seem to be an incongruous reduction because of a huge posterior wall fragment. Posterior wall is so huge that it's making the hip unstable. So even if you try to reduce it, it is going to be the same. I feel even if it is reduced hip. So this they might have tried to reduce it. It is not stable because of the large size of the posterior superior wall.
You have a 2D? 2D
I
cut.
don't think, no, I don't have, sir.
There is some impaction there.
Yeah. Yeah. So I have a question. It's a posterior dislocation with a posterior wall, and you try to reduce in the casualty, but you're not able to reduce it. Would you still try to reduce it?
No.
No.
Yeah.
No.
So how is it different from pure hip dislocation and dislocation with a posterior wall? Which would you take it as an emergency?
Okay. A pure dislocation is an
Pure
emergency because
Pure hip dislocation is an emergency.
yeah. So
Yeah.
in acetabulum fracture, what we do if it is not reducing, we will still put a skeletal traction if the pressure is deferred because we don't want the fracture edges macerating or injuring the femoral head. Yeah.
Yeah. Point taken. So you do not, if you're not able to reduce it, kindly don't, you can do it urgently, but you don't have to do it as an emergency. I think in a hip dislocation, I think it is pure hip dislocation. You should be reducing it as early as possible. That is the take point. Uh, Dr. Saji, what would be your approach? Your approach?
It is a posterior wall and a high posterior wall fracture. So I
Yeah.
think I'll go through the Cocker-Langenbach and may require a trochanteric osteotomal flip.
Trochanteric flip. Dr.
Yeah.
Sarvanan, would you add something else to your implant choice in these cases?
Yeah. Yes. Since the fragment is superior, it's quite superior and it's quite large. Along with our routine posterior wall plate, we might use something sort of a buttress plate, something like a one-third tubular plate, which acts like something like a buttress over the superior wall, over which we will be able to apply the posterior column plate. So that might be I have to keep in mind is like I might need to use that in this along with our routine posterior wall plate.
Okay,
I
point again.
think
So
you
you
may
would like,
require a trochanteric osteotomy here.
yeah. So 2 points to KL approach. You will most probably require a trochanteric flip to reach to the dome and anterior part of the wall, which is much higher up in this case. And second thing, it is comminuted and a large piece. So most probably you will require additional plates like a spring plates, like what Dr. Sarvanan was talking about. So let's go ahead. So we have gone through a Cocker-Langenbach approach. We have done a trochanteric flip, and we have used spring plates for this case because it was a comminuted a posterior wall fracture. These are the AP view, and this is your iliac view and the operator view. We have got a good concentric reduction of your hip. Any comments?
Raju, can I comment something?
Ah, sir. Sir, you are there, sir. I thought you were in a
No, no,
different
I'm very
session.
much there from the start. Anyway,
Oh,
so,
thank you, sir. No, I saw your message saying that you are going for another session.
no, 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 no. That message.
Thank you,
Acetabulum,
sir.
pelvis and sensor going away is
Thank you so much, sir.
I have another session afterwards, but right now not there. So
ठीक
anyway,
है then.
as you were just talking about doing a trochanteric flip, there is an option of using a Gibson approach.
Yes, sir.
And that Gibson approach permits reasonable amount of access to the superior area also. So as an alternative, now we frequently go for Gibson rather than doing a flip. I mean, it is just as an option which can be taken. Otherwise, rest everything is okay.
So my threshold for doing a trochanteric flip has come down drastically because of the Gibson's approach.
That is what I wanted to say.
Yeah, fine. ठीक है, sir. Anybody else has any comments?
just one question. Gibson,
Yes, sir.
does Gibson, it's more a central incision than
Yes.
going drifting posteriorly.
Yeah.
Does it cause uncomfortable situation in going back towards the ischial tuberosity and if the posterior wall is more towards the lesser sciatic and greater sciatic notch area? I mean, towards that side.
So I personally feel if you're using a Gibson's approach, your ischial tuberosity is not a problem. But if your ischial spine is much higher up, your posterior soft tissue is more than your classical KL approach. So I think you might have a little difficulty when you have a very high posterior column fracture, which is extending the spike, which is extending into the sciatic notch. That is only
No, but does the Gibson give you liberty to retract the abductors more than the standard approach?
Yeah.
Yes.
Yes, sir. Yes.
Yeah. I absolutely agree, because that
Because
is
you
the basic part where we get the advantage, because we don't have any proximal limit which we have got in cochlear leg and back.
Yeah.
In Gibson, the proximal limit doesn't exist, so we are comfortable with the abductors.
true,
Right,
sir.
sir,
In
right.
KL approach, you cannot extend your gluteus maximus extension more proximally because of the inferior gluteal vessel, inferior gluteal nerve. I think in Gibson's that doesn't arrive at all. The more the incision, the more leverage of the soft tissue retraction. Uh, we will not comment on this because we'll discuss one more case. There's another posterior fracture where there's a depression through your CT scans. If you look, this is the articular depression. So we have elevated it, as Dr. Sarvanan has already shown. You have put a graft. We have fixed it back. We have taken the graft from the trochanteric region and we have fixed it. So let's go into the other case. It would be our last case. I think we are falling short. We have another 5 minutes for case discussion. Uh, Dr. Raghavendra, now can you come to your diagnosis with a simple X-ray of the AP view? You have to unmute yourself. I can't hear you, Dr.
Sorry.
Yeah.
Oh, yeah, sorry.
Yeah.
Yeah, can you hear me now?
Yeah.
Yeah, I see both iliopectineal and ilioischial lines are disrupted here.
Yes.
So that says both columns are involved. The obturator
Yeah.
foramen is involved. So, and the ilium is intact. There's no fracture in the ilium.
Yes.
So this goes more towards a T-type fracture.
Yeah, point taken, very well taken. So we have done iliopectineal broken, ilioischial line broken, and obturator ring broken. So you're left with T-type, anterior
T-type.
column with a posterior hemitransverse and a both column fracture. Coming to the CT scans, shows no spur sign in the CT scan. So associated both column fractures is ruled out. And if you look at the CT scans, your fracture line is going from the anterior to
Yeah.
posterior. So I
That's the
think it
transverse
is
component.
transverse component. So it's more in favor of a T fracture than anterior column with posterior hemitransverse. So Dr. Saji, what will be your approach?
Anterior column, I think because the whole fracture pattern is more so, hello?
Yeah, Dr. Saji, yes.
Yeah, now I would use a posterior approach.
Okay, sir.
And try to get the anterior column screw in. If I'm able to reduce it through the posterior approach, the anterior column, or I think in terms of a dual approach.
Okay. Does the posterior wall determine because there's a posterior wall in this case?
So definitely it will be a posterior approach first.
So the posterior approach first. So would you reduce the column first or the wall first?
The column first.
Yeah. As a general dictum, I think yes, the column has to be reduced first and fixed. But in certain cases, like in this case, the column is much lower than the wall fragment or the transverse the column component. So I think I can fix the wall as a first case and make it as a single piece for my column as a single piece. Agreed?
Yes, taken.
Yes, taken.
One question here.
Yeah.
What is the point against doing an anterior column first? Because many times, anyway, you are going to require for the posterior wall and posterior column. So what happens when you are fixing the posterior wall and posterior column? If by chance you take a bite on the anterior column, then your reduction of the anterior column is just not possible. Whereas when you are fixing the anterior column, you are not going to bite on the posterior column at all. It is going to be an independent fixation.
Point, if you are doing, in this case, if you are doing dual approach, two separate approaches, I think your point is taken very well. But if you are choosing a single approach where you want to address the whole fracture component, I think that is when the posterior goes in favor first.
And you mean to say you are going to put a finger through the greater sciatic notch and fire an anterior column screw?
Yes, I will. If you look at this, if everybody can see my pointer, if you look at this CT scan, and if I put a wall and a column plate here first, then I will be going into this anterior fragment. So my anterior fragment will not reduce. The first thing, as soon as I open, I might temporarily hold my wall. I might not even hold it. I would go into the sciatic notch, into this level, take a spike, hold it one time at the superior margin, superior aspect, and under that, and reduce and fix the anterior column in this case first,
Yes.
and then address the posterior segment.
Now the second thing here is, just
Yeah.
see where is the exit of the anterior column fracture line. It's very near the sciatic notch.
Pardon, sir?
The spike of the anterior column.
Yeah.
Come back to the X-ray on the left side. On the left side, and take the posterior extent of the anterior column.
This one you are talking about, sir?
Yes, there.
Yeah.
This reduction from behind is very, very difficult, because if I'm not wrong, I'm not able to see that X-ray. Is the fracture exiting through sciatic notch also?
Yeah, it is exiting.
It is existing.
Now, if the fracture is exiting through the sciatic notch, your maneuvering is very, very near the superior gluteal nerve, and it becomes quite difficult to get that column.
Yep.
So probably I would do a infrapectineal plate anteriorly first, reduce that, then go behind and do the posterior one.
Yeah.
Sir,
Can be.
I add something? Sir, the wall fragment defines which one should go first, because we have to go posterior anyway, whether we go anteriorly or not, because the wall has to be fixed with posterior only. So I would rather go posteriorly, because the wall needs the posterior anyway. We're going to reduce the posterior column. We'll try to see if we can get the anterior column. If we get it, well and good. If we don't get it, then of course we can always go anterior, because posterior to be done is taken because the wall is there.
No, Lokesh, my point is not that. My point is these two fractures are independent. There is no doubt that anterior has to be addressed by a KL approach. But because the fracture is exiting in the sciatic notch, for you to put a hook and get that reduction, only an anterior column screw may not suffice. So what is the point in against me doing anterior AIP independent anterior column first, and then doing a posterior wall posterior column?
Point
My
taken, sir.
perception here
Thank you.
is that, as Dr. Lokesh also says it, maybe, I mean, this is a non-comminuted anterior column. So I'll feel more comfortable to go from posteriorly, try to get reduction, because it helps me in putting the posterior wall fragments in a better position because of the anterior column reduction and the part of acetabulum. The articular cartilage also is well perceived. See if it's well, and if we have been able to pass a screw across, that's very comfortable. And suppose if it is comminuted or we have failed, as Lokesh said it, we can definitely have the other choice. But first attempt should be posterior. That's my perception.
Sensor, that means even if you are going posterior, your first reduction will be the anterior column.
Anterior column. it will be anterior column.
Yes, and the point of the difference here is reduction of that anterior column with that spike width is going to be dicey. Unless you are ready to accept a small.
I agree, but our attempt should be this way. If we fail, we are ready to go anteriorly. But first attempt should be from posteriorly. There is a good option that we may not have to go anteriorly. So definitely it minimizes my.
But then this fixation is going to be through a screw, anterior column screw. From posterior.
One screw, we may put two screws. But definitely if it is reduced well, because there is no combination, the stability achieved will be sufficient because of its reduction.
So you will like to put two plates posteriorly?
Yes, yes.
Two plates.
Yeah.
Two plates.
Okay.
Okay. I think I'll show what I have done. So I went ahead and I wanted to do posterior approach. I fixed the posterior. First would be to reduce the anterior column and hold it and place a long anterior column screw, followed by posterior wall reduction and holding it, and then reduce the posterior column and fix it with plates. Any comments?
Nice.
Quite a good approach. Yeah.
Good.
Thank you.
What did you do to the split in the him?
Sir, I can't hear you, sir.
If you go back to the X-ray,
Yeah.
the ischium is split in different plane.
Yeah, it is fallen back in place.
Well, I mean, of course, X-ray is showing that, but did you try to address that in any other fashion? Because your screws are going to go parallel to the fracture line. Go to the clinical on table picture.
Picture nahi hai sir on table.
Yeah, no. X-ray, the 3D.
This one, what you're talking about?
Yeah, that one.
Sir,
Yeah.
time is over.
Yeah, fine. I think time is over with the for discussion. We have two papers, free paper presentation. Kindly be there. Bear with me for another 20 minutes. Kindly listen to this and kindly ask questions on the same. Stop share.
So should we log out?
No, be in place, sir. Don't. Papers. Yeah. 2 minutes.
I am Dr. Anand Kumar, postgraduate from Nizam Institute of Medical Science. My paper presentation is on surgical outcome in anterior column fracture of acetabulum treated with anterior intrapelvic approach and lateral window with anterior superior iliac span osteotomy. Coming to introduction, open reduction and internal fixation is the gold standard treatment for the displaced acetabular fractures. Surgical treatment of acetabular fractures is complicated due to complex anatomy. The goal of treatment is restoration of articular anatomy and stable internal fixation. This is the classification for anterior column acetabular fracture. Anterior column fractures and its associated injuries were traditionally fixed through ilioinguinal approach, which has increased morbidity with long surgical duration, iatrogenic injury to the iliofemoral blood vessels and femoral nerve, and with high postoperative complications. Anterior intrapelvic approach alone cannot address all anterior column fractures, whereas anterior intrapelvic approach with low lateral window increases access to high anterior column fractures, whereas anterior superior iliac span osteotomy in lateral window enhances the access and has a certain advantage of increased exposure up to sacroiliac joint and also helps in ilioischial screw fixation. The chance of neurovascular injury are minimized due to ASIS osteotomy, which relaxes muscles and neurovascular structures medial to it. There is a decreased surgical time, bleeding manifestations, and increased quality of fracture reduction with AIP and lateral window with ASIS osteotomy approach. Aim of the study is to study the surgical outcome in anterior column fractures of acetabulum treated with AIP approach and lateral window with ASIS osteotomy. Objectives are to study the intraoperative fracture reduction of the anterior column fracture, to study the postoperative functional outcome of the patient, and to study the intraoperative and postoperative complications. Coming to material and methods, this is a clinical radiological study including 22 patients operated in the NIMS between May 2018 and 2020 with a minimum follow-up of 8 months. Inclusion criteria: patients above 18 years of age and all patients with anterior column fractures may be isolated or combined, treated by AIP approach and lateral window with ASIS or strategy. Exclusion criteria: patient below 18 years of age, compound fractures and old fractures of acetabular. Coming to brief note on procedure, more recently anterior intrapelvic approach is commonly used for anterior pelvic procedures instead of ilioinguinal approach. Patient is positioned supine and a horizontal skin incision is made 2 cm proximal to the superior pubic ramus and deepened up to the abdominal fascia. The exposed rectus abdominal muscle is divided along linea alba to approach the internal aspect of the pelvis. On approaching the inside of the pelvis, corona mortis is identified and ligated, and subparietal resection is done along pelvic brim to expose fracture fragment. Obturator nerve and vessels are usually identified easily and are protected during further procedure. Extreme precautions are taken to protect the external iliac vessels. If AIP approach is insufficient for reduction or internal fixation, a lateral window with ASIS osteotomy is done to fix the high anterior column fractures or to fix the posterior column fracture with lag screw. These are the instruments used in the acetabular fracture reduction and the fixation. Coming to analysis of the results, we have done and analyzed 22 cases. Postoperative functional outcome was evaluated using Merlin oblique postal score system and Harris hip score system, whereas radiological outcome was evaluated with Mattas criteria. Coming to results, the mean age was found to be 38.8 years with 80% of the male predominance. In this study, 72% of the acetabular fractures are due to RTA and 28% are due to the fall from height. The mean time from day of injury to day of surgery is 7.9 days. Minimum follow-up is of 8 months and maximum is of 27 months. Ipsilateral lower limb injuries are found to be 26%. We have one case of wound adhesions which is managed with regular dressing and the secondary suturing. Coming to clinical results, modified Merlin oblique and postal score is used for clinical results. The patient was evaluated by pain, gait, and mobility on a scale of 1 to 6 for each item, where 1 indicates the worst and the 6 indicates the best state of the patient. After calculating the patient score, in my study, I have 5 patients with excellent grade, 12 patients with good grade, 3 with fair, and 2 with poor score. The mean Merlin oblique postal score is 16.2. The Harris hip score. The domains calculated are pain, gait, and the functional activity. If the score is less than 60, it is a poor. If the score is greater than 80, it is an excellent score. And in my study, I have a 7 excellent score and the 2 poor scores, whereas 8 cases have a good score and 5 cases have fair. Mattas criteria, it is a radiographic quality of reduction in AP and oblique radiographs. In my study, I have 12 cases with anatomic reduction where the displacement is less than 1 mm and 7 cases of imperfect reduction where there is a displacement of 2 to 3 mm and 3 cases of poor reduction where there is the greater than 3 mm displacement of the fractures. Mattas radiological score. In my study, I have 11 patients with excellent radiological score and 7 patients with good radiological score and 2 each in fair and poor scores. Among 12 patients of anatomical reduction, 9 patients exhibit excellent and 3 exhibit good outcome. Among 7 patients with imperfect reduction, 6 patients exhibit good and excellent results, whereas 1 has a fair result. 1 out of 3 patients with poor reduction exhibit fair result and other 2 has a poor outcome. Complications are 1 patient have an infection and 2 patients have heterotropic ossifications. Coming to cases, in case 1, a 46-year female with alleged history of fall from height and sustained transverse acetabular fractures left side. These are the plane radiographs showing the fractures on left side. These are the CT images showing the fracture. These are the intraoperative images. The first image, it shows anterior intrapelvic approach with lateral window incisions. In second image, it is a lateral window incision showing ilioischial screw passed for posterior column fracture. And these are the immediate postoperative radiographs showing stable and good internal fixation of the fracture. It is the case 2. It is a closed anterior column fracture with transverse fracture of acetabular. These are the plane radiographs and CT showing the fracture. These are the intraoperative images. In this case, fracture is fixed through lateral window with ASIS osteotomy. These are the follow-up radiographs showing good fixation of the fracture. This is a 1.5 year follow-up clinical image showing excellent outcome. This is a T-shaped acetabular fracture with central hip dislocation with segmental femur fracture same side in a 40-year male due to RTA. These are the radiographs and the CT images showing the fracture. These are the 1 year follow-up images. In these radiographs, we can see a well healed fracture with minimum sclerosis. These are the 1 year follow-up clinical images showing good outcome. Coming to conclusion, AIP approaches and the lateral window with ASA sarstatin provides good exposure from pubic symphysis to the sacroiliac joint. It reduces the tension from the neurovascular bundle, so reduces the complication. It used for the anterior column fixation with in-out in screw, and it also allows the ilioischial screw fixation. It is associated with good functional and radiological outcome with decreased intraoperative and postoperative complications. Thank you. These are my references.
I think Dr. Ramesh Sen and Dr. Dinesh Kale can have questions if you have, sir, for the paper.
No, this is the important thing is to have a follow-up of these cases, and if the follow-up is okay, then definitely we can think what was done is appropriate. And my only thing is because we had posterior elements also, so they had affected the overall results also. Getting a heterotopic ossification, etc., primarily the problem of the posterior component of the injury and not of the anterior approach. So probably we can further define the results according to that. They may be better than what have been projected as in complications because of the addition of those injuries as such.
I have a question to the speaker. Paper. How did you measure your radiological measurements based on Marta's criteria? Because every time you're going to take a new X-ray, your magnification error is definitely there in that.
Good afternoon, sir.
Yeah.
I have taken.
You get my question?
Yes, sir.
Yep.
I have taken it in X-ray only, sir. I mean radiograph with the help of calibrations in system with the help of our radiological department president.
Yeah. Anybody else has a question? Dr. Ramesh Perumal. Can we go to the next paper?
Welcome everyone. My paper is on functional outcome of acetabular anterior and posterior column fractures treated with percutaneous screw fixation. Acetabular fractures are infrequent fractures with an incidence of 3 in 1 lakh per year, generally caused by high velocity trauma such as RTA and fall from height. The objective of the surgery for acetabular fractures is to achieve precise reduction to restore the joint congruence and to fix the internal bone fragments to avoid displacement of the fracture and to allow rapid rehabilitation. Open reduction and internal fixation is the benchmark method for displaced acetabular fractures, but open reductions can increase the morbidity, causing neurovascular injury, blood loss, heterotopic bone formation, infection, and poor wound healing. An anatomical reduction with a gap of 2 mm or less is a predictor of good joint function and reduced risk of post-traumatic osteoarthritis. The percutaneous technique is recommended for non-displaced or slightly displaced fractures and in obese, osteoporotic, and elderly patients who cannot receive total joint arthroplasty. This is the Judet and Letournel classification, which classifies the fractures as elementary and associated fractures. Ours is a prospective study conducted in GMKMCH Salem from 2019 to 2020, in which 10 adult patients were included, out of which 7 were male and 3 were female. These were all the inclusion criteria. Adult patients of either sex with a closed displaced fracture and minimally displaced fractures, and low anterior column fractures, low posterior column and transverse fractures, and all fracture types based on Letournel and Judith classification involving the anterior column, anterior wall, posterior column, and posterior wall, except the ones mentioned in the exclusion criteria, were included. And these were all the exclusion criteria: patients younger than 18 years, open fractures, associated lower limb and femoral head fractures, pathological and periprosthetic fractures, and stable undisplaced T-shaped fractures, both column fractures with secondary congruence, and wall fracture not compromising its hip stability, and the pregnant females and those with associated comorbid conditions. Patients suffering from myocardial infarction, psychiatric illness, uncontrolled diabetes mellitus, hypertension, and associated major visceral injury were also excluded. Preoperative planning is crucial to understand the fracture pattern and ideal screw corridor. The use of three-dimensional CT reconstructions in addition to the plain films will help determine the location of the fracture line and angle of the safe corridor used for screw fixation. To fix low anterior column fractures using retrograde fixation and high anterior column fractures using anterograde fixation, although both methods are valid for either fractures. 6.5 mm cantilevered screws provide better stability and stronger compression forces when required. The patient is positioned supine on a flat top radiolucent table, and the operative side should be positioned near the edge of the table for easier access to the hip. The arm should be placed on the armrest in an abducted position to avoid interference with the C-arm. And these were the steps followed for anterior column fixation in our study, and these were all the steps followed for posterior column fixation. Postoperatively, a closed suction drain is kept and antibiotics were given for 48 to 72 hours, and patients are encouraged to ambulate early, passive motion of the hip on the second or third day, touchdown ambulation and crutches on the second to fourth day. Depending on the fracture pattern and the quality of the reduction, patients can weight bear as tolerated with a walker or crutches. Patients typically stay in the hospital 1 to 2 days postoperatively for pain control. The minimal weight bearing status is continued for 8 weeks in patients with simple fractures and 12 weeks in most others. Rehabilitation of the abductor muscle group is needed. The important points to emphasize with the patient are gastrointestinal symptoms, fever, and drainage from the wound that would suggest a bowel perforation. Radiographic imaging of the pelvis is performed postoperatively to assess the final reduction, and in some cases, a CT scan may be warranted. Modified Merli-Diobeng and postal clinical grading system were used for clinical evaluation, which includes pain, walking, and range of movements, and it has been graded as excellent, good, fair, and poor. The general complications is thromboembolic disease and infection, and the specific complications is nerve injuries, post-traumatic arthritis, heterotopic ossification, chondrolysis, and avascular necrosis. These are all the pre-op x-rays of one of our patients, and this is a clinical picture of the patient in the immediate post-op period, and these are all the immediate post-op x-rays of the same patient, and this is a CT scan demonstrating the fracture pattern, and these were all the follow-up x-rays, 2 months follow-up x-rays of the same patient, and the mean follow-up period of our study was 9 months, and the average score of modified Merli-Diobeng and postal method is 16, which has been graded as good. Out of 10 patients, only 1 patient had a superficial infection, and none of the other patients had any complications. All cases united within 6 months with good function. Hence, we conclude that percutaneous screw fixation is an excellent method for acetabular fractures involving an anatomical reduction with a gap of 2 mm or less. Surgery achieves exact reduction to restore the joint congruence and adequately fix the internal bone fragments and allowed rapid rehabilitation. None of the patients in our study experienced significant blood loss or iatrogenic neurological or visceral injuries. No symptomatic heterotrophic ossification was noted. The drawbacks are surgical treatment after 3 weeks are more difficult to attain the anatomical reduction due to soft tissue contracture, organization of the blood clot, and callus formation. So, if the fracture is more than 2 centimeter, open reduction and internal fixation is recommended. Thank you for giving me this golden opportunity. Thank you all.
Anybody has questions?
Yeah,
I
can I
have not
ask a question?
understood.
Yeah.
I have not understood what you say meant by suction drainage. Where did you keep suction drainage? Closed suction drain. Can you hear me? Hello.
Surnarayan. Dr. Surnarayan.
In his paper, he has said
Yeah.
that he has kept closed suction drain. Number one. Number two, did he find it difficult to use a 6.5 screw? Because we have now found for an anterior column retrograde, 4 mm screw is much more comfortable. The chances of violating the superior inferior borders are much more.
I think
Where is the presenter?
Dr. Surnarayan. Is not taking questions? Means he's not there. So yeah. Oh, he left? No. Yeah, he left. I think he has left. He's no more on screen. So, I think the questions, sir, Ramesh sir, what was the question you wanted to ask?
I think one was the same Dr. Kale has already asked about it.
Yeah.
And probably the last statement that say the fracture displaced more than 2 centimeter, even less than 1 centimeter will be difficult many times to get reduction. So probably the indications will have to be defined, because what we see is when you have a undisplaced fracture, which was said as one of the indications, we counsel a patient whether you want a surgery or you just want to take rest. So a low velocity injury with an undisplaced fracture, we don't really go for a surgery as a primary management till patient is not very keen to get out of the bed on the very next day or within a week or like that. So you try to have that counseling done. But suppose, let's say that the person wants to be out of the bed and it is a high velocity kind of a injury where the fracture is displaced and you have a chance of it displacing subsequently. So this is ideal. But then the amount of displacement up till 2 centimeter becomes little more tricky to accept.
I have also one question. Why did he exclude patients with comorbidities? I think percutaneous is a good technique, especially when you have a undisplaced fractures or very minimally displaced with comorbidities. I think those are the ideal patients where you should think about doing a percutaneous.
Reducing the operative morbidity.
Yes. He should have included those patients as a priority.
So do we have another paper also?
From pelvis and acetabulum. We have actually had 3 papers. I don't know why the third paper was not included in this session.
But the speaker should have waited for questions.
Yeah. Yes. I think 12:30 we have finished on time. Thank you everybody for keeping this pelvis and established session very active and live, and accepting my invitation, and a lot of thanks from Oasis. Dr. MV Reddy wants to speak. 1 minute.
Good afternoon. I am Dr. M.V. Reddy, the co-chairman of the scientific committee. I thank all the participants for the excellent presentations you given to us. So on behalf of the organizing committee, I thank you all.
Our pleasure.
Thank you.
Thank you.
Thank you everyone for making this successful. Thank you very much. Hope the cases were interesting.
Thank
The
you.
discussion went all well. Thank you, Ramesh sir, Dr. Kale sir, Dr. Saji, Dr. Tony, Dr. Lokesh, Dr. Perumal, Dr. Raghunathan. I always get confused with Raghavendran. I always think it's Raghunathan. Raghavendran and Dr. Sarvanan and Dr. Ashok Gavaskar. Thank you, everybody.
Thank you.
Thanks to Dr. Ramesh Babu, Dr. Yeah. Thank you, everybody. See you off.
Thank you, Lokesh.
Thank you.
Bye, Lokesh. Bye,
Bye.
Ashok. Bye.
Bye.
Kale sir.
Bye.
Thanks, Ramesh sir. Bye.
Ken sir, namaste.
Namaste.
Sir, I didn't realize you were there, sir. I thought you messaged me saying that I'm going to the next session. So I thought you were not there.
No, I
Thank
have
you.
taken your order right from the first to the last.
Thank you so much, Sen sir, for being. Thank you.
Thank you, Ashok sir.
Thank you, everybody. Thank you, Dr. Ramesh Perumal. Thank you.
Bye-bye.
Dr. Ramesh. Thank you.
Everybody. Leave. No.
Leave
Yeah.
meeting, huh? Leave.
Leave or
No.